So what exactly is neurodiversity? So as per the Harvard Medical School, neurodiversity describes the idea that people experience and interact with the world around them in many different ways. There is no one right way of thinking, learning, and behaving, and differences are not used as deficits. So if we go as per the Harvard Medical School definition, they say that neurodiversity is nothing abnormal. It's just the normal variation of the brain functioning where people experience and interact the world in a different way. And there is no one right. If I'm using my ear this way, or if I'm holding my ear with the left hand, it's both of them are right. So there is no right, no wrong, but the way of presenting, the way of perceiving the world is different, which may vary from child to child and individual to individual. That's what exactly it means. So the way of presentation, the way of thinking, the way of perceiving the world might be different. There is no one right, and there is no way of right and wrong thinking, learning, and behaving. And these differences are not viewed as deficits. So the word neurodiversity refers to the diversity of all people, but it is often used in context of autism spectrum disorders, as well as other neurological or developmental conditions such as ADHD or learning disabilities. So this is the direct reference which has been taken from Harvard Medical School definition. So as per this, it clearly mentions that neurodiversity is not a medical term. It is not viewed as deficits. So considering them to be a part of autism spectrum in ADHD, we can say that these emerging neurodevelopmental disorders like autism and ADHD are a neurodiverse conditions rather than viewed as neurological deficits. So the neurodiversity movement, a word about the history. It started well in the year 90s, and the person who started this movement was Julius Singer. He was an Australian sociologist. So the main criteria or the main purpose of this movement was to include the neurodiverse people along with the neurotypical. So at that time, you can imagine that what was his thought process when he introduced this term neurodiversity, and he wanted this neurodiversity movement to be globally understood by every person. So the main purpose was this: to promote equality and inclusion of neurological minorities, that is autism spectrum disorders, ADHDs, Asperger's, and XYZ. So while it is primarily a social justice movement, but neurodiversity research and education is increasingly important in how clinicians view and address certain disabilities and neurological conditions. So it is very, very important for us as clinicians, as professionals, to understand that do we take it as a neurological deficits? Do we take it as a neurological condition? Do we take it as a neurodiverse condition? Because then only our approach, our understanding, and educating the parents will be depending upon that thought process. So if I talk about the relation between this neurodiversity and autism spectrum disorders, what does that, how this relation comes? As I've told, neurodiversity means different way of presentation, different way of expression into the world. There is no right, no wrong. So autism spectrum disorder exactly is something related to that. It is associated, we know that it is associated with differences in communication behavior, and it varies from person to person. Some person may be able to speak very fluently, they may be hyperlexic, they may be very good at the language. Some persons may not able to express themselves at all. They might be requiring lot of, as you know, language. They might be requiring lot of communication apps like Avaz and etc. Some might be requiring lot of prompts. So that means to say that their need is varying from person to person. So these are not considered to be deficits. Rather, these are considered to be the neurodiverse conditions or the variations of the typical developing brain. So people with ASD have a lot of wide range of strengths, abilities, needs, and challenges. For example, we know that some autistic people might be very communicate verbally. Some might not be able to communicate at all, and some might be able to live independently. Whereas others might struggle a lot in expressing their feelings, their thought process, and etc. Whereas others might be very, very good in a particular type of scenarios. They might be very hyper focused. They might be very focused about a particular topic, particular task, or some of them might be having a very unique abilities in doing some calculations, mathematical calculations, and XYZ, or learning something which might not be feasible even for a neurotypical child. So such is the variation of autism spectrum disorders. That is why we use the word autism spectrum disorders rather than using the word autism. Nowadays, autism has been replaced by autism spectrum disorders because it is a wide spectrum. It is not a single term where we can include all the children. And it's a very famous saying by Dr. Stephen Shaw. If you meet one person with autism, you meet another person with autism, which means to say, if you stand 100 children of autism spectrum disorders in a line, no two single children will be ever same. And this is because there are no such rational or formulative guidelines for the management of autism spectrum disorders, because each approach and management has to be tailored as per the needs of the child. So that definition was as per the Harvard Medical School. So what does about neurodiversity as per the World Economic Forum? As per the definition of World Economic Forum 2021, this is the latest World Economic Forum which happened. And as per there, they say that neurodiversity is a non-medical umbrella term that includes the conditions like dyslexia, dyspraxia, dyscalculia, ADHD, and autism spectrum disorders. And teens with neurodivergent professionals can be 30% more productive than those without autism. So that is the importance of inclusion. That is the importance of including autistic spectrum disorders or neurodivergent kids into along with the neurotypical kids, because these are the stats which have been given that a team comprising of neurodivergent professionals, they have a better productive rate of 30% more compared to a team which is only consisting of neurotypicals. This figure I have given because there are a lot of news which comes that ADHD kids have been bullied, or autism kids have been bullied, they have been thrown out of their jobs. So all these things do happen, and we do see a lot of news about these things. But taken into consideration all those facts, the fact is productivity is much better when taken into consideration the inclusions along with the neurotypicals. So according to the World Economic Forum, everyone is different. There is no single right when it comes to how we think, learn, and behave. And that exactly are the three core features which happen in case of autism spectrum disorder: their thought process, their behavior, and the way of learning the things from the surroundings. So neurodiversity is a concept that describes these differences and said that they have a lot of challenges also, but we always forget about their strengths. We always talk about the challenges. We always talk about the deficits, their behaviors, their thought process, the emotional dysregulation. But they do have a lot of strengths, which we always neglect, which we never try to make them more and more, strengthable. But we always try to improve the weaknesses. So between 10 to 20% of the global population is considered to be neurodivergent. So this is the stats which has been taken from the research from consultancy and auditing firm from Deloitte. So these are the facts of the global population, that 10 to 20% of the global population is neurodivergent. So the term recognizes the fact that certain developmental disorders are normal variations of the brain. So our thought process needs to change, that these are considered to be the normal variations of the brain. So autistic brains are said to have highly creative and exceptional concentration, imagination, visual thought, that also tend to be systematic, meticulous, and detailed. That is what we talk about. They are very fussy. They want to keep those things in a particular way. If red comes before yellow, it should be always red. They get very annoyed if red comes after yellow. They want to keep those things in a very particular manner. What we always say, they are obsessed. They have fixations. But we always use those words in negative terms, that they have fixations, how to remove that. We never try to use them in a more productive manner in order to improve their strength. That is what exactly the Economic World Forum talked about, that we focuses more on their weaknesses rather than improving their strengths. And they have unique abilities in problem solving. We know that some of them might be having Asperger's. And Asperger is nothing but just a composition of a high functioning autism spectrum disorder or a low to mild autism spectrum disorder. So people with ADHD have great imagination and score high on creativity rather than on ADHD. We nowadays see so many creative books, which have been so many creative books, so many songs, lyrics, and so unique things. Some of them might be going into, have done their excellence in chefs or XYZ conditions. But said that this is because the creativity is quite much better compared to neurotypical kids. But that creativity has to be enhanced. That creativity has to be explored. We always tend to work on their weaknesses. So dyslexic people have demonstrated the ability to think outside the box. That means 84% of dyslexic people are above average in reasoning, understanding patterns, evaluating possibilities, and making decisions, according to the charity made by Dyslexia. So this is a very, alarming figure, in the sense it's an eye opener for us, that 84% of the dyslexic people have above average reasoning. So imagine that. So if I say that you can say, do you know how much percentage of intellectual impairment is there in the kids of ASD? It is hardly less than 20%. But invariably, we always go for an IQ assessment for each and every child on ASD. That is actually not required. Only 15 to 20% of the kids on autism spectrum disorders have intellectual impairment. That is low IQ, that is IQ less than 17. So generally, and when we go for an IQ testing, it is not done before the age of 5 to 6 years. Before that, we go for the DQ. DQ is invariably low for every child on autism spectrum disorder. That variability in low might vary from child to child, but IQ is low, or if we call the term intellectual impairment, IQ is less than 70, is only in 15 to 20% of ASD kids. So discuss those previous slides on neurodiversity. Can we say that all these neurodiverse conditions like dyslexia, dyscalculia, ADHD, autism spectrum disorders, sensory processing disorders, these are the normal variations of the developing brain, rather than telling them as a neurodevelopmental disorders or neurodevelopmental deficits? So do we need to change our medical definitions of autism as per, because there are some professionals also, and they might be parents also with professional background. When we go on to the medical textbook definitions of autism spectrum disorders, we always start the term autism or autism spectrum disorder is a neurodevelopmental disability of variable severity with lifelong effects. So I think our thought process needs to change over these definitions on medical terms, because nowadays our understanding, our thought process toward these autism spectrum disorders, neurodevelopmental disorders is changing. Rather than being considered as a neurodevelopmental disability, they are considered to be the neurodiverse conditions with normal variations of the brain. So they are considered to be the normal variants of the typical brain. But the variation might vary from child to child depending upon what challenges they are facing. They might be having mild, moderate, or severe, but these are not considered to be neurodevelopmental disorders rather than neurodiverse conditions. So probably in years to come, these definitions on medical textbooks might change. So if I talk about some mimickers of autism spectrum disorders, what are the differential diagnoses of mimickers? Many a times we see that the child might appear as an autism spectrum, might appear as an autism, but he's actually not an autism spectrum. The most important example nowadays after COVID or pandemic is virtual autism. Nowadays, we do not talk about virtual autism. What exactly is virtual autism? Virtual autism basically happens when you have an excess screen exposure. As per the WHO guidelines, a child before the age of 1 year should have 0 screen time. But before the age of 1 year, how many of us as a professional, as a parent, provide screen time to our children? Even a 7 to 8 month child cannot eat his food without the screen time. But as per the WHO guidelines, there should be a 0 screen time for a child less than 1 year. Between 2 to 5 years, the screen time should be at least 1 hour, not more than that, 1 to 1.5 hours. After 5 years, it can be 2 hours, but provided with a vigorous 1 hour of physical activity, which is must. But that generally hardly happens with everybody of us. So virtual autism is the term which has now been used when there is an excess screen exposure, when the child is being continuously exposed to the screen, and as a result, there is no exposure and there is no two-way communication. So he might behave as an autism spectrum disorder. So if we come out about the different mimickers of autism spectrum disorder, there is one is called classic autism. There is one is called autism spectrum disorder, Asperger, Rett syndrome, pervasive developmental disorders not other specified, speech language disorders, or social communication disorders. Now, all these classifications were old classifications. Okay, now speech language disorder and social communication disorder doesn't come under autism spectrum disorders. But other than this, all these classic autism, Asperger, Rett, pervasive developmental disorders, they all come under autism spectrum disorders. Only speech language disorder and social communication disorder doesn't come under autism spectrum disorder as per DSM-5. So this was the old classification of DSM-4. In DSM-4, they were using the term autism spectrum disorder. And under this, they were all coming Asperger, pervasive, high functioning, and now. But now, if we differentiate this different classifications of DSM-4, DSM-5, ICD-10, ICD-11, I will not go into ICD-10, ICD-11, that is International Classification Disease. I will only go into DSM-4 and DSM.
मैं वो पीस में पार्क देख रहा था, मेरे को पता नहीं था अपार्टमेंट है.
Please mute yourself.
आर्चिस पीस पार्क ऐसा बोला था मैंने. ठीक है.
Okay,
Thank you.
So in DSM-4, they were using the word pervasive development disorders, PDD not other specified. Now all these terms have now been replaced by a single term which is known as autism spectrum disorders. The domains were same, whereas in DSM-4 they were using 3 domains: behavior, communication deficits, and sensory. Here they are using only 2 domains, that is sensory issues and behavioral issues in DSM-5. In DSM-4, age of onset by age of 3. Now in DSM-5, they have removed the criteria for age. As per DSM-4, you cannot make a diagnosis of autism spectrum disorder before the age of 3. Here in DSM-5, they have removed the age criteria. Now in DSM-4, they were using all those terms: pervasive developmental disorders not other specified, means where the child is behaving as an autism spectrum disorder, but the features are not fitting into the criteria of autism spectrum disorder. So they gave the term PDD not otherwise specified. Now it has been replaced by social communication disorder, where the child is having features mimicking autism spectrum disorder, but it is not fitting into the criteria of autism spectrum disorder. Means there are no stimming issues, there are no sensory issues, typically which happens in autism spectrum disorder. So they have been replaced it by social communication or pragmatic communication disorder. Now another important thing, in DSM-4, they were not including the comorbidities which are associated with autism spectrum disorder, like anxiety, OCDs, gut issues, sleeping issues. Now they have incorporated these along with DSM-5. So DSM-5 has a better approach in diagnosis, better approach in defining the problems along with the comorbid conditions compared to DSM-4. So if I come to the DSM-5 criteria for the diagnosis of autism spectrum disorder, there are only 2 criteria. All those old criteria, 3, 10, initially they were 7 out of 10 has to be there in order to prove the definition DSM ASD. Now all of them have removed. As per DSM-5, which is the latest, you just have 2 criteria, criteria A and B. A is behavior, B is sensory. So in criteria A, you have to fulfill all the criteria A points, that is social emotional reciprocity, non-verbal social communication, reciprocal relationships. Now reciprocal or social emotional reciprocity means emotional dysregulation, emotional expression, how the child responds, how the child shows relations with others. In the sense, is he able to read the facial cues? Is he able to understand the facial cues? Is he able to understand the emotions of others? That is what we call about social emotional reciprocity and reciprocal relationships, along with non-verbal social communication. Means to say, is he able to understand the social cues, verbal cues, facial cues? Suppose a mother is angry, he might be giving a staring look at her, but unless and until the mother shows him tells him, he will not be able to understand those facial cues that yes, the mother is angry. That is what we talk about these criteria A. Whereas in criteria B, we talk about sensory, that is fixations, restricted repetitive stereotypic movements, what we known as stimming, and unusual sensory interest or reaction. Suppose they might be very, very fascinated about rotating things like table fan, like ceiling fan, or maybe they might be very fascinated about a particular cables or wires or a particular animal or particular colors. So these are known as stimming. So criteria B, sensory, and criteria is behavior. Criteria A should be met all the 4, whereas in criteria B, any 2 things should be there to make a diagnosis of autism spectrum disorders. Now, along with that, they have now included the comorbid conditions. Like, is there any associated ADHD? Is there any associated mood problems? Is there any associated gut problems? Is there any associated allergic problems like adenoid hypertrophy, tonsillitis, allergic bronchitis, and etc. and etc. So this is the peculiarity and better advantage compared to criteria DSM-5, because they were not including all these comorbid conditions, and the onset of disease was all type, age of onset was also there. And another thing, this DSM-5 correlates functionally with the levels of autism. That is, this is known as the functional classification of autism, ASD level 1, ASD level 2, ASD level 3, which basically As per DSM-5, when we do a diagnosis of ASD, as per DSM-5, we generally tell, as per DSM-5, the child fits into ASD level 1, ASD level 2, ASD level 3. ASD level means mild, moderate, and severe. And this typically correlates with the severity of scoring with the CARS. In CARS also, we give mild, moderate, and severe. So ASD level 1 is requiring minimal support. That is ADLs, activities of daily living. He might be requiring just visual prompt or small prompt. ASD level 2 requires substantial support. That means even in going to a particular place, he needs support at least 50% of times. ASD level 3 means requiring very substantial support. Even a small task like touch the door or come here, he will not be able to follow that. So we need to provide prompt in each and every step of ADLs, that is activities of daily living. That means the functional classification of autism as per DSM-5 and as per the scoring of CARS. Another thing, as per the autism spectrum disorders, it includes all these things, as I have told you, associated comorbidities, associated restricted interest, social communication interest, and associated problems. So as per the DSM-5, there are only two things which need to be understood when making a diagnosis of autism spectrum. There should be social communication deficits, fulfilling all those 4 criteria of criteria A, and the sensory, that is restricted interest, repetitive behaviors, or sensory insensitivities. So those things, out of these, only 2 should be met to make a diagnosis. Now coming to 2 terms which are nowadays we also use, SLD, or social communication disorder, which were not present earlier in DSM-4. They are now present in DSM-5. So most important thing is, these are the 2 most important conditions, social communication disorder and speech language impairment. These are the 2 most conditions which mimic ASD but are not actually ASD. So what are the 2 most important things which we differentiate? The most important thing in ASD, there will be typical stereotypic movements which will be lacking in speech language impairment child or in social communication disorder child. Along with that, in ASD, there will be lack of imitations, there will be lack of pretend play, whereas in SLA and SPCD, they will be present. Now, how to differentiate whether the child is a speech language impairment or it is a social communication disorder? Because these two there is a very thin margin of differentiation between the 2. The most important feature which differentiates between the 2 is pragmatics. Pragmatics basically mean the formation of the sentence. So this will be typically deficient in a child with social communication disorder. So in a child with social communication disorder, pragmatic issues will be more compared to syntax. Pragmatics mean formation of the sentences. For example, the mobile is kept on the table. It might be, instead of saying mobile is kept on the table, he might say table on the mobile or on the table mobile. So that means the formation of the sentences is affected. This is what we call as pragmatic issues. So this is typically present in a child with social communication disorder, whereas it will not be present in a child with ASD, or because there won't be any speech at all that time. Or if we compare it with the speech language impairment, there'll be more of syntax issues rather than pragmatics. So as per the DSM-5, what does this SCD mean? Social communication disorder, as I've told you. So the main problems which will be there. Now, if you look at this pie chart, you will see that at one moment of time, you will appear that it might be somewhere looking into an autism spectrum disorder, like trouble interfering with and sarcasm, difficulty making friends, using overly formal language, difficulty staying on topic, failure to use gestures, difficulty taking turns in conversation. So all those things at first instance appears to be as a social autism spectrum disorder, but it doesn't have all those typical core features of autism like stereotypic movements, sensory issues, imitation issues, pretend play issues. All these things are problems related to pragmatics, related to communication. He might be able to initiate the communication, but he might not be able to sustain the communication because of the pragmatic issues. So this is what typically differentiates an autism spectrum disorder. So it's a different diagnosis compared to autism spectrum disorder. It doesn't come under ASD. So this is one of the most important mimicker of ASD. Now, just a table to show you what are the differences between the 2. As per DSM-4, we were using all these terms: autism, Asperger. We might give various diagnoses to the child. He is an Asperger. he is a pervasive developmental disorder, not otherwise specified. It doesn't make any difference. All these are basically a spectrum of autism. There was no such social communication disorder in DSM-4. In 2013 it came, but at that time in 2011 I think it came, but at that time there was no such term social communication. Now it has come, because we have seen many children with autism spectrum disorder do not typically behave as an autism with lack of stereotypic movement. They won't be there, but they have issues related to communication. So that is what, in those children, they fit into the criteria of social communication. Red disorder comes under DSM-5 only. They have now removed it. Is a part of autism spectrum. So these are the different terms, like reading disorder, we call it dyslexia. Mathematic disorder, we call it dyscalculia. Phonological disorders now we call it as a speech sound disorder. And another term, speech language impairment, which was not there earlier in DSM-4. Now they have included in DSM-5. So these were some of the basically the understanding of autism and the mimickers of autism spectrum disorders as per DSM-5. And we have learned about somewhere about what is neurodiversity and what our thought process, how we are changing our understanding towards the definition of autism spectrum disorders. Now let's see about the etiology of what are the causes of autism. Now, said that the causes of autism are endless, or they might be no cause, they might be n number of causes. We don't know. And we can't go into the causes of autism because we can't do anything much about that. But nowadays, our thinking, nowadays, a lot of things have been coming about relation to epigenetics. Everybody knows about genetics, but there is a new thing which is now coming, epigenetics. Now, have you ever wondered that we generally say autism is a genetic disorder? Genetics is a part of autism, and autism has been associated with genetics. If that is the thing, then why is that children with autism spectrum disorders show improvement over a period of time with therapies, with interventions, with supplements, with diets, XYZ therapies, XYZ interventions which we are doing? Why children with autism spectrum disorders show improvement? If parents are dedicated and professionals are dedicated towards a particular child, definitely after a period of 2 to 3 years, there will be definitely improvement in a child in terms of his ADLs, in terms of his expression, etc. Why is that? If there would have been a genetic cause, there would have been no improvement at all in autism, because genetics is one which you cannot do anything. It is affected, you cannot reverse it. Then why the children with autism spectrum disorder show improvement over a period of time during an adolescence? The reason is because epigenetics. Epigenetics basically means change in the variation of expression of a gene, which can be changed over a period of time. So there are some things happen in the body which causes the expression of the gene in a different way. For example, there is a gene which causes our expression to speak A. So instead of that, there's some problem happen in that expression of gene. Instead of speaking A, it causes B. So because of that, it causes expression in a particular child. That is the phenotypic expression. That is how the child behaves, looks, and perceives the world. So these changes are transient, which might happen due to XYZ reasons. We'll see that. And because of that, if we are able to modify those changes, the expression of the genes behaves in a normal way. That is what we call as epigenetics. So in etiology of ASD, there are a lot of things like environment, epigenetics, genetics. But I will be focusing, there is another which is known as neutrogenetics and neutrogenomics. Neutrogenetics means your genes affect how your body responds to food. Means your genes will be behaving in a way what food you take. So the better quality of food you take, the better will be the expression of genes. This is called neutrogenetics. Neutrogenomics means what food you eat, that will affect the expression of the genes. So it is vice versa. The effect of genes might be affected by the food you eat, and the type of food you eat will affect the expression of the genes. So this is what we work on, gut-brain axis. This is what we talk about biomedical interventions. This is what we talk about the importance of food, importance of diet, and in relation to epigenetics. So this is somewhere a proposed model of ASD. If we talk about the epigenetics, they say that some activation happens in the immune system of the mother, which causes the transmission of some viruses in the body, in the fetus of the mother, and which causes the maternal immune activation and causes the expression of some of the factors mimicking a child and ASD, what is known as ASD. So this is the proposed model of ASD on the basis of gut-brain axis, on the basis of this theory of epigenetics. So we'll understand this. What does this slide means? So what does epigenetics mean? So epigenetics basically means it's a modification has been considered to play a crucial role mechanism of autism spectrum disorders. So epigenetics is the study of phenotypic changes caused by dynamic and reversible changes in gene expression. So remember, I'm telling that epigenetics is the dynamic and reversible changes in gene expression, whereas genetics is non-reversible. So in humans, the main mechanism include DNA methylation, post-transcriptional histone modification, chromatin recombination. Now, what are the epigenetic factors which causes autism spectrum disorders? Now, there are a lot of research has been going on epigenetics in relation to autism spectrum disorders. The three most epigenetic mechanisms which are responsible for causing autism spectrum disorders are DNA methylation, histone modification, and miRNA modification. Now, methylation, DNA methylation, many of us might be hearing. That is, what is DNA methylation, histone modification, and miRNA modification I'll be discussing. So these are the three most important epigenetic factors which are responsible for causing autism spectrum disorders in relation to epigenetics. Now, these are modifiable factors, so they can be modified. Because of that, our focus is more on epigenetics rather than genetics. So DNA methylation in a simple way means, we have a structure in our body called DNA, and DNA is responsible for the expression of all our genes because it's a spine of our body. Now, methylation, DNA methylation means there is some group is there, a molecule is there called methyl group, which gets bind to the DNA molecule, and that binding of the DNA molecule, the binding of this methyl group to the DNA structure is known as DNA methylation. This is very, very important because suppose imagine this is a structure of DNA, and it has 5 segments, 1, 2, 3, 4, 5. And in a neurotypical child, the methyl group binds onto the molecule 1 of DNA structure. This is the normal binding, and as a result, this binding of methyl group to the DNA structure will result in the normal expression of this gene in our body. Now, this DNA methylation is responsible for thousands of enzymatic reactions in our body. That is how our cell express, how we behave. That is the normal functioning which we do. But suppose imagine due to XYZ condition, this this methyl group binds to molecule 2 on the DNA structure. So that means the binding has happened on the wrong side. Because of this defective DNA binding, methyl group binding to the DNA structure, it happens what we call as defective DNA methylation. And this is the culprit for all the process of ASD. So this is the basis and this is the concept of epigenetics, that what is happening in DNA methylation. So defective binding of the methyl group on the DNA structure is considered to be as a proposed epigenetic mechanism for the causing ASD. So can we do something about this expression? Can we bring about this methyl group back to this? Something or the other can be done on that. Let's see. So over the past 3 decades, there has been a sustained research activity devoted to correlate methylation patterns in ASD as a result of advancement in next generation sequencing technologies. Now this binding, that is defective binding, I'm using the word methylation pattern ASD, there has been a lot of research has been done where they have found that there is a defective DNA methylation is happening in different ASD kids. Depending upon how much defective the binding of methyl group in the DNA molecule is, the severity of ASD might be there. Suppose it has to bind here, it has bind here. So the gap is too high, so severity might happen more. Suppose instead of binding here, methyl group has bind to here. So it is just a mild effect. So the child might be expressing as a mild ASD. So this is what the concept of different methylation patterns has been observed in ASD. So most methyl tags are bind to the DNA molecule called cysteine C. So this is the normal structure. Just an example, this cysteine C is the structure where it has to bind. Instead of binding here, it has to bind to some other structure. So this DNA methylation is very, very important for the neuronal development. That is the development of a brain structure, development of a neurons, our sensory system. And that exactly happens in a child's ASD. Although the stat says only 75% of the kids on autism spectrum disorders have sensory processing disorder. But in my clinical practice and in my experience, I would say that 96 to more than almost 100%, if not 100%, 99% of the kids on autism spectrum disorders have sensory processing issues. And because of that, probably as per DSM-5 now, they have introduced the criteria of sensory processing disorders as a criteria B in order to make a definition of autism spectrum disorder or define autism spectrum disorder. because very rarely we see any child without sensory issues if he's diagnosed as an autism spectrum disorder. And 80 to 90% of the children diagnosed with autism have methylation impairments. So that is why it is very, very important to work on the methylation, to work on the DNA methylation pattern, because 80 to 90% of the children do have methylation impairments. Now, those methylation impairments vary from child to child, may vary from different patterns, but studies have shown, yes, they do have defects with 80 to 90% with methylation patterns. That is, the binding of methyl group might not be bind to a normal at a normal position, which it should happen. So a growing body of research indicates that methylation influences the development of autism. And one of these studies, most important, is MTHFR gene. Now, MTHFR gene is very, very important. That is called methyl tetrahydrofolate reductase, because this gene plays a very, very important role in the conversion of 5,10 methyl tetrahydrofolate reductase to 5-methyl tetrahydrofolate reductase. Means to say, when the folic acid which we take, it doesn't go into the body as such. Why many of the children autism spectrum disorders have been prescribed iron, they are prescribed with folic acid. That is what the reason is, because folic acid or the folate doesn't go into the brain as such. For this to go into the brain, because folate and folic acid are very, very important for the brain, for the neuronal function, and for the neuronal development. But when you take folic acid as such, even if your doctor is prescribing folic acid, doesn't go into the brain as such. The folic acid has to be converted into active form, which is known as 5-methyl tetrahydrofolate reductase, and then only it goes into the brain. But for the conversion of this folate into 5-methyl tetrahydrofolate reductase, you require an MTHFR gene. If the MTHFR gene is not working, or if it is defective, then there is no way that if you give folic acid, it will cause any benefit to the child. So along with that, so this is one mechanism, that is MTHFR gene. Along with that, other thing which has been found is folate receptor antibodies. Sometimes what happens, the MTHFR gene is functioning properly. That means it is converting active form of it is converting folic acid into active form of folic acid. That is 5,10 methyl tetrahydrofolate reductase. But from there go into the brain, there are some receptors are there which are called as folate receptor antibodies, which prevent the binding of this into the brain. I will show you in the slide. Now this is the diagram. This is a very complex diagram. We don't go into the details. Just remember two things, that 5,10 methyl tetrahydrofolate reductase has to go into the brain. And for this, we require this MTHFR gene. Sometimes it might get converted into an active form, but there might be some folate receptor antibody which are present on the brain, which prevent the going of this active form into the brain, which can also called as cerebral folate receptor deficiency or cerebral folate deficiency. So you might have heard about some terms that there is a condition which is known as cerebral folate deficiency. It happens because of the presence of folate receptor antibodies. So children on the autism spectrum disorders sometimes might not show any improvement in spite of giving folic acid. The reasons could be either they might be having folate receptor antibodies or they might be having MTHFR gene deficiency. This is the take-home message from that. So along with this, so what are the environmental? So these are the two most epigenetic factors, that is DNA methylation and how this DNA methylation plays an important role. MTHFR gene is important and folate receptor antibodies are important. So now what are the environmental factors which can express this defective DNA methylation? I have told you epigenetics means specifically binding of the methyl group to the DNA in a different pattern. So what are the factors which can affect this binding of the methyl group into the DNA? There can be n number of factors. Like if the mother has been exposed to a bad obstetric history, if the mother during the pregnancy, if she has been taking some antibiotics, or if there is a bad obstetric history, or if the child has been born preterm, or if the mother is having a lot of infections, gestational diabetes, or there is a lot of bleeding, or the maternal age is very, very advanced, specifically in the primary, when the mother is being conceived for the first time. We call it as an elderly primigravida when the age is more than 30. So that is another risk factor, that is advanced paternal age, maternal age, infections, and other risk factors like low birth weight baby and all those things. If there is a bad, if there is a prolonged nursery stay in a child who is born, that is neonatal infections. So all those things causes a bad trio of maternal immune activation, dysbiosis, and oxidative stress in the body. Now, what does that mean? In a very simplified way, suppose a mother is being conceived, and during the pregnancy, there has been a lot of stress in the body, which can be either in the form of medical conditions, which can be in the form of environmental conditions, which are actually not present in the body, but the body has been stressed out, either due to family stress, financial stress, uh, professional stress, emotional stress, or bad family environment. So all those things, along with the medical conditions, we don't know, it can be any of these, causes the defective expression of the DNA methylation. That is what we call as epigenetics. So these factors can be endless. You cannot do much about that. But what you can do is, whenever these things happen, try to work on those things, what are causing the stress in the body. Because these are some things which we can work on. Either there is a stress in the body, either there is due to some infections, either there is some maternal XYZ stress. So all these factors causes the defective expression of the genes. And that defective expression of the genes causes the activation of maternal immune activation in the mother. What does it means? All these stress, I have told you, causes the defective expression of the genes. That is defective DNA methylation. That is epigenetic changes. And all these things causes maternal immune activation, which is called as MIA. Now, when there is a maternal immune activation happens, there is a lot of release of cytokines. Most importantly, the most important studied one is interleukin 17. Although other are also there, like LPS, tumor necrotic factor alpha, etc. But when that happens, that maternal immune activation happens, it causes a lot of release of cytokines. And all these release of cytokines and all these things, they causes gut dysbiosis. Gut dysbiosis means there is an excess disbalance will happen between the good and the bad bacteria. And when this disbalance happens, the bad bacteria, that is the beneficial ones, we call it as a lactobacilli and bifidobacteria. The bad bacteria, especially the propionic, corynebacteria, they releases lot of propionic acid. Now, propionic acid, excess amount of propionic acid, although it is a SCFAs, they are considered to be good. But when there is an excess amount of propionic acid releases, they causes along with that lot of release of toxins, neurotoxins, tumor necrotic factor, which through the gut-brain axis might affect the expression and other things in terms of behavioral expression, in terms of synaptic pruning, and all this causes an effect in the what is called the redox potential or DNA methylation pattern. So this cycle is a totally vicious cycle. One part might be stimulating the other part, and as a result, dysbiosis, maternal immune activation, and redox oxidative stress happens in the body, and ultimately the child might land up into an autism spectrum disorder. So this is one of the proposed mechanisms for in relation to the school of thought in terms of epigenetics, how it can affect. So epigenetics is basically your environment, your medical conditions, your problems, how it affects the expression of the genes. So another epigenetic mechanism, what they have mentioned is histone modification. Histone is basically a protein which is present in the, on a part of the chromosomes. And this protein is basically responsible how the chromosomes functions and behave in a different way. So this modification has also resulted in different expression of the genes. Another one is miRNA modification. Now these are not very much considered to be, these are still in research, but DNA methylation has proved to be, has proven in a lot of studies and research and literature, and even in experiments, that a lot of animal experiments have done, and they have been found that DNA methylation is one of the most important epigenetic mechanism which has been responsible for causing autism and is present in 80 to 90%, as I have shown you the stats. So this is basically a summarization of how these epigenetic factors can affect. What type of diet you take can express the expression of the guts, that is gut microbiota. That is what is called in nutrigenomics and nutrogenomics. And that expression might affect the gut dysbiosis, that is the balance between the good and the bad bacteria. And because of that, there might be changes in the, what I have told you, that is dysbiosis. There'll be immune activation, which might happen. Might be release of lot of tumor necrotic factors, that is cytokines release might be there. Inflammatory markers might release into the blood, and that release of inflammatory neurotransmitters into the brain, like tumor necrotic factor, alpha interleukin, and etc., can affect the expression of the genes. So this is how this how gut dysbiosis, how metal immune activation can affect the expression of the genes, that is through either DNA methylation, histone modification, or miRNA modification. But among these three, the most important is DNA methylation, which is present in 80 to 90% of the kids on autism. Now, these are some of the miRNA modifications which has been taken from miRNet database, and they have found that these are the different expressions of miRNA which has been found in ASD kids. So this is another epigenetics role. Now, if I talk about something about biomedical evidences or biomedical testing. Now, as I've told you that mitochondrial disease, the prevalence, what we do about metabolic testing, what can we do about, we do sometimes do a lot of metabolic testing in kids on ASD. Why it is so? The reason is because the prevalence of mitochondrial disease in ASD population is estimated to be around 500 times higher than found in the general population. The prevalence of abnormal metabolic markers is even higher, suggesting that as many as 30% of children with ASD might experience metabolic abnormalities. Now, these mitochondria is considered to be as an engine of a body. It is a it is basically a most important, and we know that mitochondria plays a very important role in stimulating lot of cellular processes, lot of cellular and enzymatic processes in our body, and it plays a very important role as a detoxifying agent in our body. Now, almost 1/3 of the autistic children have documented elevation levels in plasma lactate to pyruvate ratio, and the levels of many of the mitochondrial markers. So many a times we do these testings of pyruvate, L-carnitine level. The reason is, and even urine for organic acid, the reason is to check for the mitochondrial dysfunction. Now, mitochondrial disease is something different. Mitochondrial abnormality is something different. So here we are talking about mitochondrial dysfunction or mitochondrial dysfunction, and which has been found to be 500 times more in autistic population compared to the general. So what are the biomarkers which will give us an indication that yes, there is an associated mitochondrial dysfunction in a child on autism spectrum disorder? So these are some of the indirect biomarkers towards mitochondrial dysfunction: pyruvate, carnitine, and ubiquitin. So as per the American guidelines, as per the American Academy of Pediatrics, when do we do the metabolic testing in a child or mitochondrial workup in a child? If there is a history of atypical regressions, if there is a family history of early childhood or death or diagnosed with metabolic, or if there are physical features which are suggestive of hypotonia, weakness, visual or hearing impairment, or if there are dysmorphic features, or children who present with motor delay should be evaluated for creatine kinase or thyroid stimulating. So majorly, approximately more than 50% of the kids on autism spectrum disorders do have motor delay. So as a result, just give me a second, please. Yeah, sorry. So what are the indications for this mitochondria as we're telling? If there is a history of atypical regressions, if there is a family history of early childhood or death, and if there is a history of motor delay. Now, majorly, approximately more than 50% of the kids who are on autism spectrum disorders, they do have motor delay. They might be having gross motor issues, they might be having fine motor delays, but definitely there will be a motor delay. So invariably, every child on autism spectrum disorder, we generally go for a thyroid testing. Though in in many of the kids, it might come out to be a normal. But these are some of the indications for metabolic testing in a child on ASD as per the American Academy guidelines. Then another test what we can go, we go for urine for organic acid testing, that is urine organic testing. We generally go for routine. We go for acyl carnitine metabolic levels or L-carnitine levels, which gives us an indirect marker of mitochondrial functioning. Now, as of now, there is no evidence at this time to go for routine testing of hair, blood, or urine for environmental toxins like lead and etc. But heavy metal testing is only indicated if there is confirmed cases of high risk exposure, like there are factory employees or there are people who are or parents who are living near the industries. So routine testing of heavy metal heavy metal is not required in blood and hair as routine when you are going for a workup for diagnosis or for investigations in a child with autism spectrum. This is only in relation to metabolic or mitochondrial. We have not talked about gut or food intolerance issues and etc. Because our topic is focused on certain things today, so we are discussing only on that part. So if I talk about gut dysbiosis, as per the American Academy of 2017 recommendations, gluten and casein Ig level testing is beneficial in subset of ASD kids showing symptoms of intolerance. Routine testing is generally not required. So we generally go for an IgG levels when routine testing should not be done. Routine testing of IgG or IgE should be done, but better we should go for an IgG levels because they will give you a better compared to an IgE, because studies have shown that 70 to 80% of the kids are more sensitive to IgG levels compared to IgE levels. But routine testing again is not recommended. Now, this is a bit about how these SCFAs. Now, SCFAs, we know that SCFAs are short chain fatty acids, and they are considered to be good because they help in improving the tight junctions between the mucosa. They help improving the absorption of the food. They help in improving the mucus thickening, and also they help in improved absorption of the food from the gut and improving the immunity and adaptive power of the gut healing. But said that, there are three most important short chain fatty acids. The three most important are acetate, butyrate, and propionic acid. Now, when there is a disbalance happens between the good and the bad bacteria, that is dysbiosis happens, the amount of Clostridium, that is propionic acid, Clostridium species increases very, very high. And these are considered to be non-beneficial because beneficial is the lactobacillus and bifidobacterium. So when there is an increased production of Clostridium, they release lot amount of propionic acid. Now, one thing is very, very clear is anything less is bad and anything excess is bad. So that this statement typically applies to the propionic acid. Now, when the dysbiosis happen, the Clostridium species increases very, very high, which has been shown in studies also that the majority of the kids on ASD, when there is a dysbiosis, Clostridium species goes very, very high compared to the lactobacillus and bifidobacteria. And these Clostridium species releases propionic acid. Now, the amount of propionic acid which is released by Clostridium species is in very, very excess amount compared to another type of species which are releasing. So as a result, the propionic acid which is released in very excess amount compared to the amount which should be released in a neurotypical or in a child which is not having gut dysbiosis. So when the amount of propionic acid goes in excess, it causes the release and stimulates the inflammatory pathway. That is the release of tumor necrotic factor alpha, interleukin 17, interleukin 6, and etc. As a result of this, there is an inflammatory cascade, or means there is a release of toxins which goes from the gut to the brain and causes stimulation of all those sensory issues and etc. So this is exactly what happens when there is gut dysbiosis and how this gut dysbiosis stimulates the sensory system. So this is the chart which shows you that what are the levels. So we can go for stool testing, where we can go for short chain fatty acid testing in the stools, which will give you an idea. Just give me a second, please. Yeah, which will give you an idea that how much amount of propionic acid, how much amount of SCFAs are produced. So the normal levels, if you see, they are given the range. This is an example of the test which I have taken, where the amount is shown. So this test, this is an example of stool comprehensive analysis test, where you will get an idea of the different type of SCFAs which are produced. So if the amount goes in excess, that is an indication of gut dysbiosis. Along with that, there are other tests like fecal calprotectin levels, which I have mentioned you in this slide, like fecal calprotectin levels, zonulin levels. So these are all the indirect markers of gut dysbiosis. But in India, we generally only go for fecal calprotectin and zonulin levels. Only these two tests are there, which has been done in India. Other than this, no other tests are being done. So conclusion is, if we go for a metabolic testing and other things, investigating a child with ASD is very, very challenging. So generally when we go, we generally divide the investigations into different levels. Level 1, where we go for the general routine investigations. In level 2, we will go for specific investigations like calprotectin zonulin levels to check for gut dysbiosis. Stool for yeast and comprehensive analysis, there are yeast overgrowth issues like humming, uncontrolled laughter. Then we might go for the heavy metal testing only if there are low cognitive skills, frequent behaviors in spite of good therapies which are going, still the child is showing low cognitive skills, or if there is a strong history associated with an exposure to industries. And there is always a debate that whether heavy metal toxicity is the cause of autism or heavy metal toxicity has been occurred as a consequence of autism. Because these children, they do have a lot of mouthing issues. They take a lot of things in the mouth. That is also a reason for excess heavy metal toxicity in the kids. So indirect markers of mitochondrial dysfunction like L-carnitine, palmitin, food intolerant panel test to be checked if the mother gives us a history of intolerance, which might be in the form of gut issues, behavioral issues, attention issues, sensory issues. So level 3 investigations like genetic testing, which should only be done if there is an associated problem of genetic in the mother family, or there is dysmorphic features, or if there is an associated history of Frank's scissors, then only we should go for an EG. So these are these different levels of investigation which we can go for in a child when we are planning to go for an investigation in terms of biomedical approach. Now, if we go about in terms of gut and autism, although I've discussed a bit about gut and autism, but I will go little in why we want to study gut in autism. Because one thing is there, we can do a lot of about gut, because if the gut is in a bad shape, definitely your senses will always be in a bad shape because of the concept of gut brain axis, which has been proven without any doubt. And in majority, and the problem is with the senses in the child on the spectrum. The core feature is senses, that is sensory system is affected. So if we are able to modify the gut, if we are able to make the gut healthy, probably we might be able to make the senses much better compared to the present state. So that is what is talk about gut brain axis. So the most common comorbidities which are seen in the children autism spectrum disorders, we know that there are constipation, diarrhea, bloating, nausea, and there can be any other symptom among this. But the most common ones which are presenting is constipation and diarrhea. So if you see, the human gut consists of approximately 1 kg of bacteria, and the number of bacterial genes in the gut is approximately 9.9. And if you see, we as in humans have a DNA, and in our body there are a lot of small microbes and insects and small microorganisms are there. They have their own DNA, and our DNA is just 1/10 of the microbe DNA. So you can imagine we are just we are more of a bacteria rather than a human body, because our body is being dominated by the microbe DNA rather than our own DNA. So if I talk about what is a microbe, these are just defined as a collection of microorganisms which are present in a human body. When I talk about a microbiota, it means it's a collection of microorganisms at a particular site. So the microbiota can be at the skin, it can be at the intestines, it can be at the stomach, it can be in the saliva. So microbiota means collection of microorganisms at a particular site. So we talk about gut microbiota specifically. That means the collection of microorganisms in the gut. And when I talk about microbiome, microbiome means the genetic material of these microbes. So nowadays our understanding, as I've shown you in the epigenetics and all those things, that basically is an elaborate expression of those previous slides. So microbiome is the genetic material of these microbes which are present in the body, and due to XYZ reasons, their gene expression of these microbes get disturbed. Because of this disturbance of these microbes and gene expression of these microbiome, there is an overgrowth of excess bacteria, there is an undergrowth of some bacteria. And because of this, it might result in dysbiosis, and as a result, the whole process happens. Now, this microbiome expression can happen because of XYZ reason, which we have seen: maternal stress, environmental stress, physical stress, medical stress, diet you take, or what junk you have. So seeing that, discussing that, probably you can now give a thought to your mind that yes, these are some things which we can do and correct. And probably this is one of the reasons that why many of the children, when go for a GFCF diet, maybe there are many professionals, they might go against that. But yes, many of the children who go on a GFCF diet, when under proper guidance, when under proper testing for the indication of what level of intolerance is there, they might show a lot of improvement in their senses in terms of behavior. And this is the reason why that happens. So the human microbiome, its composition, its complexity and function is greatly influenced by individuals' health, diet, hygiene, and genotype. Now, said that, it doesn't mean that every child should go on a GFCF diet irrationally. There has to be a rationale on following a GFCF diet, because you are putting a child on a restricted diet. You are playing with his nutritional requirements. So it is very, very important what additional nutrition has to be given to a child so that his nutrition and growth is not compromised. And on the basis of his, what is his level of intolerance to the child in terms of his levels of IgG or IgG. So what is the role of this gut microbiome? These gut microbiome are very, very important. They help in vitamin nutrition, absorption, immune cell, maintaining our immunity, and XYZ reasons. Dysbiosis I have discussed. There is an imbalance between the gut, the good and the bad bacteria. And this dysbiosis is considered to be one of the proposed mechanisms for autism spectrum disorders. Other than this, there are other disorders like inflammatory bowel disease, Parkinsonism, Alzheimer, and etc. But our focus is on autism spectrum disorder. So what happens whenever there is gut dysbiosis? There is a channels are there between the gut. Now there is the lining between the gut. These channels get break, and as a result, what we call as a leaky gut. And because of those things, there is an inflammation happen. That means the release of toxins and XYZ reasons. And why does this leaky gut happens? That is again the stress, the toxin, the type of food we take, the drugs, and or malfunctioning or bad bacteria. Another important thing is studies have shown that children with autism spectrum disorders take 3 to 4 times more amount of antibiotics compared to a neurotypical child. The reason is either they might be having frequent diarrhea, they might be having frequent throat infections, they might be having frequent allergic manifestations. As a result, invariably they have been put on an antibiotic. And a single course of antibiotic can worsen the gut microbiota by 9 times. So these are the facts which I'm giving you. This is not my statement. These are the facts. So a single course of an antibiotic can affect the gut microbiota by 9 times. So as a result, when you want to reverse the gut microbiota, you have to give a course of probiotics minimum for a period of 3 to 4 months in order to make the reverse of the changes. So this is the some alarming facts which do happen in children on autism spectrum disorders, which we need to look that irrational use of antibiotics should not be given in a child, whether it is a neurotypical or whether it is an ASD, but more importantly, in a neurodiverse child, irrational use of antibiotics should not be prescribed unless and other if it is really indicated. So if there is gut dysbiosis, this is how the structure of your gut will appear. A normal gut will be containing mainly these lactobacillus and bifidobacteria, which are considered to be good bacteria. But when there is gut dysbiosis happens, you can see in the right side, right circle, all the amounts of good bacteria, that is lacto and bifidobacteria, have gone down. Only the good bad bacteria have been popped up, like Candida, Strepto. These are all bad bacteria, Klebsiella. And we do see a lot of Candida issues, a lot of yeast issues in children with autism spectrum disorders. This is the reason. And another reason is whenever they do have constipation, they do have gut issues, their emotions, their behaviors, their cooperation, their ADLs decline drastically. The reason is because of this. So what are the factors which can affect the gut microbiome? If I have told you the maternal diet, that is what type of diet the mother takes. Whether she's taking a high fat diet, whether she's taking low iron, whether she's taking low calcium. That is why we always insist on taking iron and calcium during the antenatal period. Whether she's been taking smoking, antibiotics, alcohol consumption. So all these are factors which can affect the gut microbiome of the mother. If this gut microbiome is affected, there is a maternal immune activation, which I have discussed. So another mode is the mode of delivery. It has been found that children who have been born through cesarean section the probability of going into an autism spectrum disorder is high compared to children who have been born through cesarean section. But said that, it doesn't mean that every child who is born through a cesarean will go into an autism spectrum disorder, and every child who is born normally will not land up into an autism spectrum. No, it is just a probability which increases the chances of going into a child on autism spectrum. Just give me a second, please. Yeah. So the reason is because when a child is born through a normal delivery, the microbiota which is there in the mother lining, that is in the vaginal canal, that is considered to be beneficial. That is lactobacillus. So that is transmitted into the fetus. But when a child is born through the cesarean section, the microbiota which is present on the skin of the mother get transferred to the fetus. And the microbiota which is present on the skin of the mother is considered to be bad, unhealthy. So as a result, it is found that children who have been born through a cesarean, the chances of probability of going into ASD is little higher compared to a child who is born through a normal delivery. Another thing is, what is the type of feeding we take, whether the child has been breastfed or whether the child has been formula fed. Now, here comes the concept of HMO, that is human milk oligosaccharides. The child who is being born, the child who has been taking breastfed, there is a special molecule which is there called human milk oligosaccharide, which is present in the mother's milk. Now, it acts as a prebiotic, and when you give it, it specifically increases the growth of good bacteria, only like lactobacillus and bifidobacteria. And as a result, it increases the growth of these bacteria invariably. Whereas if a child is being on formula fed, we are giving gauze and phos. Now, gauze and phos, these are prebiotics, but they do not specifically increase the growth of bifidobacteria or lactobacilli. They can increase the growth of bad bacteria also. So that is why it is always recommended that the child should be given breastfeeding exclusively for 6 months, and beyond that, along with that, you can give complementary feeding, but breastfeeding should continue. Now, nowadays, we are using HMOs in healing the gut in the children of autism. So many of our patients are being on an HMO, and I think the results are good. And the reason is because if you give a combination of an HMO like a prebiotic along with the probiotic, so the results containing these lactobacillus and bifidobacteria, the gut might be healing in a better shape compared to another prebiotic, for example, like inulin, because inulin is not specifically increasing the growth of good bacteria. It can increase either the good and the bad, but HMO is a unique prebiotic which specifically increases the growth of good bacteria. So this is one concept, that how the feeding can affect the gut microbiome. Now, there are a lot of evidence for this, that gut dysbiosis in ASD. So these are a lot of studies I have given, and the results reveal that gut dysbiosis has been found to be associated with ASD. I won't go into the details of this, but this is one of the Indian studies which has been done by AIMS. Another studies like evidence of role of gut microbiota in ASD. So in all these studies, they have found that children who have a gut dysbiosis, spectrum kids, they have low levels of gut microbiota, they have low levels of bifidobacteria and lactobacilli. But other species might vary because the expression of these microbiota is also influenced by a topography, by a geographical distribution. So a child or a person who is living in Western might have a different presentation of the microbiota than a child who is living in South Asian country or a Pacific. So this is because of in relation to the topographic and geographical variation. But the common thing which was found, that the amount of beneficial bacteria, lacto and bifidobacteria, was drastically low in all children on spectrum with bad gut, irrespective of the geographical and topographical distribution. So gut-brain axis, I have told there's a connection between the gut and the brain, which is connected either through the chemicals, neurotransmitters, emotionally, and through the nerves. So just a brief about this gut-brain axis, because I have to touch on all the parts. So this is the gut-brain axis. What happens in the gut-brain axis? Whenever there is a gut dysbiosis, there is an altered gut microbiota. The bad bacteria increases, the good bacteria goes down. Inflammatory cascade happens. The toxins are released into the gut. There is already a leaky gut is happening. So all these all these bad toxins like propionic acid and human necrotic factor alpha cytokine, there is an inflammatory process which goes into the brain, and from the brain they causes synaptic pruning and neuroinflammation. Now there is one thing what is called reduced synaptic pruning. Now synaptic pruning, basically, now you might have heard that in ASD kid there is a reduced synaptic pruning. Synaptic pruning means connecting unwanted connections. Now whenever a child is born, there are a lot of synapses or neuronal connections are there. But when he has to go into a more sophisticated manner, these unwanted neuronal connections should cut down. This is what we know as synaptic pruning. But these unwanted neuronal connections doesn't cut down. As a result, they remain there is an excess neuronal connections are there. As a result, the child might face sensory overload. Even given a single command, he might be feeling as though he's getting the command from different corners of the side of the wall. So as a result, he gets confused. This is because of an unwanted synaptic connections which are still present. And this synaptic pruning happens because of the presence of macrophage, which are considered to be our most important brain macrophages. They are responsible for this synaptic pruning. And that doesn't happen in kids on ASD. It is because of all these factors, and as a result, there is an irritability, aggression, impulsivity, and behavioral issues. So if I take a brief about this, gut dysbiosis plus defective synaptic pruning is considered to be a cause of ASD. This is one of the proposed mechanism for ASD as per the gut-brain axis theory. So we have discussed about the gut, we have discussed about the brain, we have discussed about the etiologies, we have discussed about the understanding of the autism spectrum disorders as per neurodiversity. Now, if I discuss about another important topic is socialization skills in autism. We might do a lot of things. We might be able to make the kid learn. We might be able to make him understand the speech and everything. He might be start expressing his desires. But the problem again comes socialization. Socialization is a big issue in children with autism. So let's discuss about a brief about what are our understanding and why there are social deficits happen in autism spectrum disorders. If I use a very simple term, what does socialization means? Socialization basically means how you interact with others, how you greet with others, how you communicate with others, how you read their facial cues, how you understand their behaviors, how you understand their emotions, how you understand their feelings. This is what we call as social skills. And all these social skills definitely are lacking in children on autism spectrum disorder. So what are the facts? Why these social deficits happen in autism? There are three most important theories which has been given in children why they have social deficits in autism. The first theory is called as social deficit theory or social motivation theory. This is the first theory. The second theory is theory of mind. The third theory is the neuronal underconnectivity theory. Now, among these, the most accepted theory why social deficits happen in autism is social motivation theory. Now, this theory states that there is no motivation in the children autism spectrum disorder to mingle. They don't have any motivation. They don't have any desire to mingle. And the reason is why they don't have this. Let's understand. So this is the most accepted theory, which as per this theory, they say that there is no motivation or no desire to interact with others. And that is what is called as the social motivation theory. The second theory is theory of mind. Now, theory of mind has been obsolete, is now not considered to be as the preferred theory. The reason is, as per the theory of mind, they say the theory of mind refers to the ability to understand the desires and intentions and belief of others. This is a skill which typically develops in a child between 3 to 5 years of age. But the problem is, before understanding the feelings of others, the children with autism spectrum disorders are not able to understand their own feelings. They already are in a state of social emotional dysregulation. They are not able to understand their feelings. How you can expect that they are able to understand the feeling of others? They are already fighting with their own emotions. They are in a state of self dysregulation. How we can make them understand their emotions of others? So as a result of this, the theory of mind is not considered to be an accepted theory for happening the social deficits in children with autism spectrum disorder. The third theory is called as a neuronal underconnectivity theory. Now, this theory is also accepted, but the most accepted theory is social motivation. As per this theory, they say that in the children with autism spectrum disorders, the back portions of the brain. The back portions mean there is an occipital and parietal regions of the brain. They are have a strong connections. And because of these strong connections, the prefrontal region or the prefrontal cortex, which is the main region or the cortical region, which plays a very important role in judgment making, socialization skills, logical thinking, is underdeveloped. Because the connections here between the occipital and parietal, the back portion of the brain, are strong compared to the connections in the frontal region or the prefrontal area of the brain. As a result, those socialization skills are poor in children on autism spectrum disorder. So let's talk about a brief about social motivation. Now, as per this, the social motivation theory is the most accepted theory for social deficits in children. Now, there are three components are there for socialization skills to happen in children. The first is social orientation, social reward, and social maintaining. Social orientation means the child should get oriented towards that. That yes, there are some kids are playing. I would be oriented towards them and I should go there. Then social reward means he should feel pleasure in social interactions. Then social maintaining. Now, sometimes what happens, many a times we see a child is there, he's sitting alone and there are 4 kids are playing. And he won't be not at all bothered there to look at them. That means there is no social orientation. Now, when there is no social orientation, how you can expect them to get a social reward and social pleasure? Many a times parents might put up the child in between those 4 kids, but after maybe a 3 to 4 minutes, he will go back because he's not having any social reward. There is no social orientation. So he cannot maintain social maintenance. Social maintenance means he will continue to play with them. So this is the 3 components. So we cannot directly ask the child that go and sit. Many a times parents tell, sir, he doesn't play with the kids. Now, playing with the kids is the last step in socialization. Before that, he needs to have an orientation towards them. He needs to have a pleasure. He needs to have that pleasure. Yes, if I go there, I will feel pleasure. I feel happy. When those orientation and pleasure things are not there, how can you expect the child to get mingle with them directly? So this is what. So we need to work on the initial 2 levels, then only we can achieve the level 3. So this is the most accepted theory, and this happens because of the disbalance between the GABA, serotonin, and glutamate. We know that glutamate is the inhibitory neurotransmitter. Glutamate is the most excitatory, and GABA is the inhibitory transmitter. Now, this disbalance is there between children on spectrum. This disbalance of neurotransmitters is there. This is another theory which says, and another theory which says that the limbic system of the brain, which plays an important role with emotions, regulations, is underdeveloped compared to the other regions of the brain. So these are what are the most important early predictors of social skill development? How you can detect or how you can improve the social development, socialization skills in a child. Now, there are 3 most important things: joint attention, imitation, and eye contact. Now, joint attention, imitation, and eye contact, these are the 3 most important fundamental skills for the socialization to develop in a child. Because if these things are not there, we cannot make a child socialize. So joint attention means is the ability to share a common focus on something. For example, in this example, both of them are looking at this particular object with complete eye gaze on that particular object. So this is known as joint attention with particular pointing towards that. Now, for the joint attention to happen, there are 3 most important things which needs to be present. First, you should have an intention to look towards them. You should have an emotion. For example, I give an example. Suppose many a times what happens if a parent tells to a autistic child or the child who's on the spectrum that look, there is a plane going on, he will look there, but he will not himself show that mama, there is a plane going on. So this is what we call as social. This is what we call as responsive joint attention and initiative joint attention. The child might initiate. The child might respond. That mama, there is the mama might tell there is a plane going on, so he will look at there. So this is responsive joint attention. This will be more or less present in every child on spectrum. But what is lacking is social joint attention, initiation. Mama, there is a plane going on. There should be a desire. There should be an orientation towards that plane. Then only the child will show that mama, there is a plane going on. So he will never show by himself there is a plane going on. But if you tell her, he will look. So that is what we call as social joint attention or initiative joint attention. That is more important than responsive joint attention, which is lacking in children on autism spectrum disorders. So these are the types of joint attention which I was telling you: responding to joint attention and initiating joint attention. So showing us something particular by the child itself is known as social joint attention, or initiating joint attention, which is more important and which is considered to be a social joint attention rather than responding joint attention or responsive joint attention, because responsive joint attention many a times is present in children on spectrum. Then joint attention deficits in young children, why do they happen? Children with kids, they don't orient to certain speech sounds. They have deficits in referential looking. And another thing is there is a disbalance between the neurotransmitters, excited and inhibited neurotransmitters. Many times we say that joint attention is not important, eye contact is not important. If he's doing the work, that is fine. He might be able to do that work, but those typical socialization skills in a social scenario will not happen. They will be still struggling. Because many times we see that even a child might be doing a lot of good things, but still at the age of 10 to 11, he's having problems in socialization. Second most important thing after joint attention is imitation. Now, imitation is something which child imbibes naturally. But children who are on the spectrum, we need to teach them how to do things. That is what we call as imitation. Now, teaching imitation is a very big task in children on spectrum. There are 5 stages of teaching imitation in a child on spectrum. They can be first what we call as full physical prompt. Suppose this is a cup. I have kept the cup from here to here. A neurotypical child will imbibe me and will put the cup like this from here to here. Okay, but a neurodiverse child will not be able to do that. So first thing you give what is known as full physical prompt. Take his hand, hold the glass and pull it directly from here to here. So this is, you have done this task from here. This is full physical. Then you give partial physical prompt. That is, just give him a support, because they might be prompt dependent. So you just give him a support and complete the task with him. This is partial. Then you might give him what is known as verbal physical prompt. Okay, put this glass from here to here. So this is a verbal, because you have to give him a direction from where to where. Then it can be verbal, then it can be only visual. You are just showing your visuals. That is eye movement from here to here. Don't speak. So this is how you improve the levels of prompt, because a child who is not able to attend any imitation skills, in that you have to give him a full physical prompt. Whereas a child who is attaining good imitations and is progressing further, you might just need to give him a visual prompt. So this is how the level of hierarchy of prompts need to be given to a child, depending upon his levels of attaining imitations. Then what is the role of imitation? Now, in typical, I have told you, imitation generally emerges in the age of between 2 to 3 years. But generally nowadays it can even happen imitation. The earliest imitation, reciprocal imitation, which happens at the age of 6 months. We'll show you that in the figure. So the role of imitation means it will help in learning functioning. It will help in socialization. It will help in understanding the thought process. It will help in improving the receptive skills and receptive language. Now, this is the earliest skill which is present in a child. That is reciprocal imitation, which appears as early as 6 months. What is this reciprocal imitation? If you take a 6-month-old child and you give him a hug, he will smile on you. This is a typical example of a reciprocal imitation. So which can come as early as 6 months. So many a time there is a question is how early can we detect autism? We can detect early autism as early as 6 months by this reciprocal imitation. It will be typically lacking in a child who is on a spectrum. He will not show any smile. He will not show any facial recognition. But to make a diagnosis of autism, the earliest is 18 months. But to detect autism, earliest is 6 months. So imitation deficits in autism, as I have told you. So social imitation means use of body language. So social imitation means use of body language. That is what I was telling you, that imbibing, how a neurotypical child can do things depending upon how he looks into the environment and how he imbibes, which is typically lacking in a child on the spectrum. Then you have the eye contact. The third most important socialization skill to improve the socialization skill or early markers of socialization is third is eye contact. Now, eye contact is another important thing, because even if you are not speaking, your eyes are the most important things, because they will give you a strong sense of communication. They will give you a strong sense of confidence. And if you are able to maintain a good eye contact with a person, this will give you a self-confidence in you. Because a child, you can yourself imagine, if you are not confident about a particular topic, if you are not confident about a particular thing, you will not be able to give an eye contact to that person. Or if you are nervous, you will be looking here and there. So your eyes are the mirror of the soul, and they will an indirect marker of your confidence, and will boost up your level of confidence in communication with others. So that is why eye contact is always very important. You don't have to, force them to give an eye contact. You have to motivate them to give an eye contact. So why do these autism kids why children on spectrum have poor eye contact? As I have told you, that is, there are the theories which has been saying that there is a disbalance between the inhibitory and the excitatory neurotransmitters, that is GABA and glutamate. So socialization skills. Now this is known as a socialization funnel. Now, if I go on to the socialization funnel, the most important thing is sensory awareness. Then it comes about your awareness, social awareness. Then it comes about focus, then emotions, then socializations, and then executive functionings like logical thinking, calculations, judgment making, task deciding, all those things. But many a times what happens, parents many a times parents do complain that sir 8 साल का हो गया socialize नहीं करता. अब अगर आप उससे पूछो सर आई कांटेक्ट है, फोकस है, सेल्फ अवेयरनेस है, सोशल अवेयरनेस है, नहीं है, then how can we expect them to a child to go into a socialization immediately? Because awareness, focus, and emotions, these are the three most important things which need to be attained before you go into the socialization. And to improve this awareness, focus, and emotions, the three initial pillars of socialization skills of funnel, you should have eye contact, imitation, and joint attention. Because eye contact, imitation, and joint attention, these are the most important things to develop social awareness, self-awareness, focus, and emotions. Unless and until these are not developed, you cannot go into the stage of socialization. Forget about executive functioning. So that is why we need to work on these steps, and gradually the improvement will come. We can't jump directly onto the 10th step forgetting the lower part. So this is the importance of socialization funnel. And that is why I have highlighted the importance of eye contact, imitation, and joint attention. Sensory play, because it gives us an awareness. Sensory play is a play which a newborn plays. Now this is very, very important, because this sensory play gives him a sense of touch, awareness, surroundings. And there are a lot of things which you can do with a sensory play. There is a sensory basket. There are a lot of things which you can keep in your sensory room. And what are the benefits of sensory play? Engagement with the environment, interest with the surroundings, language development, emotional regulation, and tactile touch problems. How he can feel his touch, how he can sense those things. So these are the benefits of sensory play. So you need to figure out, is your child out of this sensory zone, or if he's still in the sensory zone? If he's still fighting with his paste, if he's still fighting with the colors, if he's still fighting with the paste on the skin, if he's still fighting that there should not be any food on the mouth, if he wants to rub gel from his hand, if he keeps rubbing his hands, these are all indications that he is still sensory intolerant. So we cannot expect him to directly go into the socialization. We need to work on these sensory issues. All those sensory issues will not go completely in any child. Here and there, there might be some, but at least they should not be to that extent that he is already engorged, always engorged in those sensory zones. So that is important. That needs to be, we make the child to go out of this sensory zone so that we can proceed into the next level of socialization funnel. So always remember, follow your child's lead interest, always your child freedom to explore and ideas, try to stimulate multiple senses. And there is a SEAL module, that is social emotional academic learning. SEAL module says that you cannot jump directly onto an academic learning. Initially, you should develop socials, then you go into the emotions, and then you go into the academics. And before these socials, you should have a self-awareness, focus, attention on the basis of eye contact, joint attention, and imitation. So this is how we progress onto the socialization funnel. So these are some of the evidence-based approaches to improve joint attention and imitation. I won't go into the details as we have discussed many times. Pivotal response training. natural environment training, discrete trial training. Discrete trial training means breaking a single step, breaking a command, a single step command, like go to the kitchen, into small commands with positive reinforcement, with a reward and with cues. Social stories and peer mediated, that means involving a lot of peer group, or what is known as play therapy. So another important thing is how to prioritize your therapies. Many a times you might go to a professional. He has diagnosed that your child is on the autism spectrum disorder, and he has labeled XYZ therapies, speech therapy, play therapy, or this XYZ, or special therapy, special education, occupational therapy, sensory integration. But then it becomes a very big problem to the parents, what to do, how to price your therapies, what therapies needs to be done. Although there is a lot of financial issues, the therapies are not too, they are too expensive. It's not like that they are cheap, they're expensive, financial burden, time, there is a lot of time needs to be spent. So a lot of things happen. Acceptance doesn't come easily. Then family pressures, friend pressures. So a lot of things needs to be taken into consideration when you decide on prioritization of the therapies. So there are some decisions which can be taken in order to decide how we can proceed with the interventions to taking therapies. These are not guidelines. These are my, my viewpoints, and these are my viewpoints after interaction with the parents and after my own experience with the parents and interacting with them. So the first most important step, which I feel, is acceptance. Acceptance never doesn't come easily to all family members. Maybe father and mother are accepted, but there are grandmothers, grandparents are there, which might still say, अरे बोलेगा डॉक्टर तो ऐसे ही बोल रहे हैं, ये भी ये पड़ोसी का बच्चा भी 5 साल पे बोले तो स्कूल जाएगा बोलेगा. Now by the time those things happen, he is already 6 years and he is not speaking, but the severity of the problem increases. Though the acceptance might come, but there might be a family pressure that don't take to these therapies, it's not required, is absolutely fine, thoda chanchal hai, thoda tantrums hai, single child hai. You can see a lot of things happen, and a lot of family pressures and peer pressures come. So the first and foremost important thing is there should be a unanimous acceptance in all the family members that yes, something is there which is not going in the right path for my child. And if you can accept that, there is nothing wrong in that. Step 2, you should have a detailed assessment with the developmental pediatrician or the clinical psychologist to know the severity of your issues with the child. It's not that we have to label it, or we have to make you go into a state of negative thought, or we have to, harass you. It's nothing like that. But the only thing is we should know the level of severity the child is having, so that accordingly interventions can be done. Step 3 is read about autism books through nets, books, authentic websites. Why I have mentioned that? Because a lot of things are happening in the name of autism. I don't want to name those therapies because all of us knows. So just you should be very authentic about what treatments and what things are authentic, what not, and what is best for your child. At the end of the day, you have to take your decision whether this is right for my child or not. Because you might be going to the therapies, you might going to the doctors, they will be telling you continuously so and so, okay, you can come, it will take time, XYZ. But that is fine, it will take time. But you are the person, you are your person who is with your child 24/7. You know your child best. So you have to take a call whether what intervention you are doing with your doctor or therapist is right or not. If it is not, take a decision to switch. And you should be bold enough to take a decision. Because if you feel there, oh, if I take a decision, I might not lose that, I might lose that therapy, what will happen to my child? Then a negative thought and that fear will come, and you might continue with that therapies in spite of thinking that my child is not being getting benefited. So discuss with parent or support group family members and take decision accordingly. Be in touch with senior parents who are very much well versed and whose children have gone into the state of adolescence with success stories. Don't depend upon others. Every minute is crucial for your child. Stress is the importance of intervention. So early intervention is very, very important. Early intervention means as early as after birth, when you detect a child is having some issues, start intervention. So many a times 5 years, 4 years we come, but the results are low. The reason is because a 5-year-old child develops a brain development is equivalent to the child of a 40-year-old child, 40-year-old person. And a 40-year-old person, you cannot make him to do things as per your needs. He will tell, who are you? I am not your boss. So I will do things as per my way. That is why early intervention stress is there. You can mold your child as early as possible as you feel. Step 4, enroll in interventions and also have regular discussions with your doctor or therapist regarding the plan of action. Many a times you go into the therapies, the parents are not allowed what is happening. There are no cameras access. What is happening inside, nobody knows. After 45 minutes to 60 minutes, it comes, हाँ ये कर रहा है, आप घर पे जाके कराओ. That should not be the idea. You should have a complete clear transparency. Even in our center, even in our therapy, we do have cameras. We show what therapies are going for each and every child in every zone. So that is important because it keeps a transparency and a trust between the parent and a therapist or a doctor. And you can have a plan of action after each every session. This is the progress, and we have a plan that at the end of 1 month, we should achieve this target. We achieve or not, that is a different thing, but we should have a plan. So become a therapist for your child at home. That is what I'm telling. You do take that 45-minute session at therapy center or at anywhere, but that 45 minutes you should incorporate into 2 hours with your child at home and work on intervention as per the ability of the child. At last, never lose hope. So the reason why I'm telling that many a times what we do, that we always focus on target. We never focus on, we always focus on target. We never focus on goal. मेरा बच्चा 5 साल का है, उनका 5, इसको 1 to 100 तक आना चाहिए. Even if he learns 1 to 100, if I tell him, okay, pick 2 chocolates, he doesn't know that functionality of 2. What does that function 2 mean? Then what is the use of learning 1 to 100? So that is what I'm telling. Our intervention target should not be target, it should be goal. Our goal is he should understand the concept of 2 rather than going on to a target of learning 1 to 100. So your intervention should be goal oriented rather than target oriented. So role of interventions are very, very important, should be goal oriented rather than target oriented. Identification, invitation, joint attention invitations are very, very important. Don't overload your child with questions. Give them a guiding tool regularly as a therapist, and also you become a therapist for your child so that you keep on working with your child on a regular basis. So at last, believe in you and your child efforts, results definitely come. Now, at last, I will be giving you understanding about the primitive reflexes. Now, what is primitive reflexes and what is the use of this primitive reflex integration? Now, what are primitive reflexes? Now, primitive reflexes are nothing but these are autonomic stereotypic movements which are directed from the brain stem with no cortical involvement, means thought. It means in a very simple language, when a child is born, you have seen, everybody must have seen their kids then when they were young, when they were below the age of 12 months. They must be moving their legs here and there. They must be moving their hands here and there. But you might have observed one thing, their movements are stereotypic, means they are typically, their movement will happen in different way. They might be using this, they might be moving hands, and they'll be going as typical stereotypic movements. That means in a typical fashion, it will be repeating again and again, cycling movements and etc. But these movements do not carry any thought because they are originating from the back portion of the brain. As I have told you that in earlier slides, where I have shown you the concept of socialization, the back portions of the brain are strongly developed in children on spectrum. As a result, the thought process is not good because the front regions of the brain, the cortical regions are poorly developed, the neuronal connections are poor. And as a result, they are having poor social skills. Another reason is because they have retained primitive reflexes, because primitive reflexes are occurring from the back portion of the brain. Okay. And when the primitive reflexes integrate, these neuronal connections which are present at the back portion of the brain, they get weak. And naturally, the front portions of the brain connections become strong. This is the reason that when a child gradually progresses from 12 months to 1 year to 2 years, his intellectual thought, his process, his understanding, his thought, his speaking skills becomes better. Why it becomes better? You don't have to teach them. They naturally starts learning. Why? Because when a child is born, the neuronal connections at the back portion of the brain are strong. As a result, the primitive reflexes are there. When the child starts growing, naturally these connections become weak and front portions become strong. That is, socialization skills starts developing, sensory system starts developing, simultaneously the primitive reflexes starts integrating. Integrating means they get gradually start fading off. So this process happens simultaneously. And in children on spectrum, you will see even a 5-year-old child has socialization skills, thought issues, emotional dysregulation, thought processes. This is because the primitive reflexes are still retained. This is because the neuronal connections at the back portion of the brain are strong. So this is the concept of primitive reflexes. So infants have a wide range of movements like activities including kicking, waving, stretching, rocking. So these are totally uncoordinated movements, but these are typical stereotypic. They will happen in a regular fashion. Okay. And when a child gradually starts developing, he will start losing all those movements. You don't see a 3 or 4 year old child lying down on the bed and kicking like an infant or moving his legs, cycling movement. No. Why? Because the primitive reflexes has gone. You might have seen an infant who is lying with the bed with the legs folded and on the tummy and with the head folded down, because these are because of the presence of primitive reflex. A 3 or 4 year child might not do that. We'll see those things and when we discuss about those primitive reflexes. Now, all these movements are important because these primitive reflexes are important because they help in understanding their senses, surroundings. And if these reflexes over a period of time should regress in order to develop the sensory system more and more better. So when I talk about these reflexes, they have a journey. They have a typical journey. That means they will emerge at a particular period. That is at the birth, they start emerging. By the period of 7 to 8 months, they start developing. And at the peak by 12 months to 1 month or 12 months to 14 months, they are at the peak. By the time at 12 to 14 months, they should start regressing and they should get completely leave the body. That is what by 14 months, the child will start developing. He will start walking. He will start speaking a word. He will start understanding the surrounding. He will start looking around the world. This is because the back connections are becoming weaker and weaker. The front portions of the brain becoming stronger and stronger because the back reflexes, the primitive reflexes are getting transformed. So this is the normal journey of the reflex: emerge, develop, peak, integrate, and transform, and goes back. This should happen by the age of 12 to 14 months in every child, but it doesn't happen. Why? Because of the presence of retained primitive reflexes. Now, what can we do in order to integrate or remove these primitive reflexes? There we use the word what is known as primitive reflex integration exercises. So primitive reflexes, first the child is born, there are primitive reflexes. These primitive reflexes get transformed into postural reflexes, which are known as lifelong reflexes. That is, making the body to stand against the gravity. Like suppose a 12-month-old child might be able to stand against gravity. He starts walking. That means his primitive reflexes are now getting converted into postural reflexes. Sometimes we say that iski walking kab shuru hui. He might be at 18 months. He might be 20 months. That indicates that postural reflexes were attained late, or there was a delayed integration of primitive reflexes of a particular reflex. So this is a very, very important delayed walking is a very important, developmental milestone, or which indicates that yes, her primitive reflexes might have been retained. For example, crawling, creeping. Generally, crawling and creeping happens by the age of 8 to 9 months. A 10-month-old child doesn't crawl or creep, but sometimes even a 12-month-old child might be crawling and creeping. That means to say the primitive reflexes were retained. STNR is one of the most important reflex which plays an important role in crawling and creeping. Now this should regress by the age of 10 to 12 months. It should go away. STNR should integrate. But sometimes parent is a street, sir, उसने delayed crawling करी थी. वो 10 महीने पे शुरू किया और 13-14 महीने तक crawling करता रहा. That means STNR didn't integrate. It integrated delayed, or it appeared late. So this is the importance of these primitive reflexes. Now, whenever there is any possible stressor which might cause the retention of these reflexes, and what are those possible factors? It can be either before birth, that is bad obstetric history, mother stress, environmental factors. Yeah, mother has taken some antibiotics, or during birth, child was born through a cesarean, or there is a complex delivery, low birth weight, or there is a lot of blood loss during the pregnancy, or after birth, the child was having a lot of infection, was staying in the environment, in ICU. So it means to say that the stressors are endless. So we cannot tell that, okay, this could be a possible reason. We can only tell this might be a reason that has caused the child to land up in an autism spectrum disorder. But said that many a time the child is born normal, with a normal delivery, with a good birth weight, up to 3 to 4 years is absolutely fine. Then suddenly there is a complete loss of regression. He stops speaking and everything. That is another thing, what is known as autism regression or regression autism. So said that, it doesn't mean that what caused that autism into the child. We don't know. So there are n number of causes. To some we can able to find the causes, to some we cannot find the causes. But these are some of the school of thought, some of the theories which has been given in terms related to retention of primitive reflexes. So each reflex is very, very important with one or more of the sensory processing system. That is why I have given you this slide, that once initially the primitive reflexes comes, then the postural reflexes come, and these postural reflexes play an important role in the development of sensory system. So primitive reflexes are very, very important for the development of sensory system. And you can see sensory system is the most important backbone of a body, because this is the most important system which is being affected in children autism spectrum disorder. So each reflex is associated with one or more sensory processing: auditory, taste, tactile, smell, visual, vestibular, proprioceptive, and interoceptive. These are the 8 important sensory systems of our body. And therefore, if a retained or child is present with this experience dysfunction in one or more the sensory, this can lead to what is known as sensory processing disorder. So integration of primitive reflexes. Integration means the primitive reflexes should fade off, should go away from a body. It is very, very important, because only when they will go away from a body, our sensory system will develop. Sensory system means the vestibular, the sensory, the memory, the behavior, the emotions, and learning. Only because they will go away means this sensory system, our emotions, our learning, they will develop means our subcortical, the cortical region of the brain, the frontal region of the brain, which plays an important role in socialization, judgment, will become strong. And as a result, we will be able to develop a normal sensory maturization brain system. So sensory system, if I talk, there are 3 most important sensory systems: vestibular, proprioceptive, and tactile. These are considered to be the near senses. Vestibular, proprioceptive, and tactile, these are near senses sensory system which develop first. Once they develop, automatically the far senses system, visual, auditory, smell, and taste, will automatically develop. In majority of the times, vestibular and proprioceptive and tactile, these are the 3 most important dominant sensory systems. If we are able to work on them, naturally the other far sensory systems will automatically develop. But many a times we are so much many a times we are so much engulfed into only into these 3 sensory systems that we are not able to make the child come out of this. So as a result, he will be feeling those far senses will almost every time will be affected. So most important, we need to work on vestibular, proprioceptive, and tactile. If we are able to work on them, the other senses will become better, because these are the most important near senses. So indications, what are the indications for persistence of primitive reflexes? These are some of the indications. There are endless number of indications, but the most important, I have taken it out: feeling overwhelmed and stuck, fear of separation, elective mutism. Now, I will not be going to the detail of primitive reflexes, because primitive reflex integration, I have taken a webinar, we have taken 3 sessions on that. Each webinar, it was a total 6 hours workshop on primitive reflex integration. So it's not possible. So I will be just touching on the importance of these primitive reflexes. So feeling of overwhelmed, stuck, fear of separation, elective mutism, that means is not speaking at all, finding it difficult to make eye contact, difficulty in forming own opinions, that is emotional dysregulation, fear of negativity, fear of thoughts, perfection, eating disorders, withdrawal from social situations, negativity, constantly anxious, which are very important. Anxiety is a very important comorbidity in children's spectrum. So these are some of the indications which will give you that yes, my child is still having some primitive reflexes. Now, if I go into the details of particular reflex, for example, Moro. The Moro reflex is a reflex which gives you an attention towards your fear. It gives you a sense of protection. Now, an example to make you understand: a 3-month-old child, if you just make him, you keep him in the hands and just throw down, he will just grasp like this. A Moro reflex means hand goes down and grabs come like this. Why? Because he feels that I may get hurt. So he tries to protect his body, but it doesn't know that he will not get hurt. It's a pseudo fear. So Moro reflex is basically cannot differentiate between a pseudo fear and a true fear. And this is a typicality of a newborn. A newborn cannot know whether this is a true fear for me or it is a false fear. There is a fear, he will show the reflex mechanism, that is Moro, in order to protect. But just doing that will not cause any harm to the child. He doesn't know that. But this typically example, if I take in a 5-year-old child, a 5-year-old child, sometimes you might have seen a 5-year-old child in spectrum might be fear of that insect. Mama, that insect, Mama, that insect, Mama, that dust is coming, Mama, that thread, I'm fear of that. Now, Mama will be telling, you might be here that there are some unusual fears. Mama, I'm fear with that light, I'm fear with that color, I'm fear with that puppy. Mama will be annoyed. Why are you fear? You might be continuously explaining why are you fear with that. This is nothing. It will not cause any harm, but he still has that fear in him. That is a pseudo fear. That means a 5-year-old child is still not able to differentiate between a pseudo fear and true fear. That means to indicate a moro is active. So this is an important clinical clue which gives you an indication that the moro is still active in a child. And moro should get transformed into an adult startle reflex. Adult startle reflex means where a child will show his body, will the child will go into a state of protection when there is a true fear. For example, you are standing and suddenly there is some dog comes. So a 5-year-old child, when sees a dog, he might suddenly protect himself, or he might run. So that is an activated startle reflex, which is a modification of moro reflex, which is present in adult, and it should be present. It's a normal reflex. But a fear with an insect in a 5 to 6-year-old child indicates that moro is still active. That means primitive reflex is still active. So this is what are the general challenges which you can feel with the moros. There are a lot of things which you can feel, but I have just given you one example: highly anxious, infections, motion sickness, impulsive, hypersensitive. So these are the most, and moro reflex plays a very, very important role in development of auditory, visual, vestibular, and proprioceptive. That is why moro is invariably present in more than 90% of the kids in one spectrum, because it plays an important role with vestibular and proprioceptive. Then you have the rooting reflex. Now, rooting reflex is another important reflex which plays an important role with tactile and proprioceptive. Now, many a times what happens, you might see when a child is writing, he might be taking out his tongue out. When he's writing, he might be using legs, he might be making fists, he might not be able to remain in a state of calmness while writing. He might be fidgeting with his tongue, he might be taking out his tongue. That is because of the rooting is activated, because rooting plays an important role with tactile and proprioceptive. When he's writing, there are tactile sensory system is activated and proprioceptive is activated. But because his tactile and proprioceptive are not developed, because of the retained rooting reflex, he makes his tongue or tongue out while writing. So this is an importance of rooting reflex. Palmar reflex is similar to that, like pencil grasp. There'll be difficulty in writing, there'll be continuous movements of the tongue, there'll be difficulty in articulation of speech. So palmar reflex will be retained in a child where there are articulation issues, phonological issues. And the important sensory system is tactile and proprioceptive. Again, along with the rooting, palmar will also show that the child might be continuously speaking utterances while writing. He might be continuously speaking unnecessary things or making his tongue out like this, making movements of his tongue while writing. This is a typical example of retained palmar and rooting. Now, another important reflex is ATNR, which is associated with auditory, vestibular, and proprioceptive. A child with an ATNR will have difficulty in differentiation between the right and the left movements. Right? When we talk about figure of 8 activities, or when we talk about mid crossing over activities, the child finds it difficult. This is because ATNR is important. ATNR is activity. ATNR helps to differentiate the laterality of the body. What is right, what is left. Children with autism might feel difficult in making the decision whether to go right, whether to go left. They might be finding difficult in mid-crossing activities, like badminton playing like this, or handover activity across the midline, or difficulty in right and left. This is because hand coordination issue. This is because ATNR is activated. ATNR plays an important role in differentiating the laterality of the body, what is right and what is left. Similarly, STNR. Now, STNR is another important reflex which plays an important role in debilitating poor posture neck retention. Many a times when a child is writing, he will be bending neck like this, completely low down, or they might be debilitors. They might be poor postures. Most important, rather than poor posture, debilitator and poor neck control while writing is an important indicator that STNR is active. So in order to retain that, we give an STNR rock. Now, that is a total different topic. We don't want to go into that. Now, this is a normal typical pattern of an infant sleeping, maybe 12-month, or maybe 10-month-old child. But sometimes children on spectrum, even a 5 to 7-year-old child, they have given, sir, wo aise sota hai. Typically, they will give us an example of this. They have shown me the photos. This typically indicate that STNR is active. Then TLR. TLR is called tonic labyrinthine reflex. Now, tonic labyrinthine reflex basically gives you an movement where the different parts of the body, especially the upper part of the body, the neck, and the rest part of the body, the lower limbs, that is next move, legs move. For example, when a 7 to 8 month old moves his legs, he always moves his neck. He cannot move the legs without the movement of neck, because the differentiation, because the body, the lower part of the body is connected to the upper part of the body. This is mean TLR is active. But when a child grows above the age of 2 years or maybe 1 year, these movements happen differently. But sometimes you might have observed when he's playing, he will be moving his head. He might be eating, he might be kicking. Many a times the mothers will be telling, stop moving your leg movement, just eat quietly. But whenever he's moving his head and taking, he might be kicking, he might be moving his leg, fidgeting. That indicates TLR is active, because the upper part of the body is not differentiated from the lower part of the body. He is not able to make the independent movements of the upper part and the lower part of the body. That is what an indication of TLR, tonic labyrinthine neck reflex. I'm trying to explain it in a very simple way. So TLR plays a very important role with vestibular, proprioceptive, and auditory. I have given you the most important reflexes which plays an important role in attention with vestibular, proprioceptive, and auditory, because primitive reflexes are an important part of integration for the development of sensory system. Spinal gland. Spinal gland is another important reflex which plays an important role in the development of proprioceptive and tactile. So the general challenge which we feel, if the spinal gland is activated, there might be dribbling issues. There might be urination issues, that means poor bladder and bowel control. They might be finding it difficult to wear very tight pants. They might be wearing it very loose pants, and they might be speech and articulation issues. Now, there is another reflex which is known as fear paralysis reflex. This is just a modification of Moro's reflex, which is present in the infant when the child is inside the uterus. So I don't want to go into that reflex. So the main thing is, whenever there are glitches or stretchers, whenever there are glitches and stressors due to XYZ reasons, there is an activation or retention of primitive reflexes. And as a result of activation or retention of primitive reflexes, the sensory development of the brain is poorly developed, or there is an underdevelopment or poor maturization of the nervous system is compromised. So as a result, all this happens and causes the poor development of the sensory system. Now, this is an FPR, is similar to the Moro's. I don't want to go into the detail of this. So another important thing is emotional regulation. Now, why humans have emotional regulation and emotions compared to animals, or compared to animals? The reason is because they have a strong limbic system. Limbic system is one system which plays an important role in emotional regulation, memories, decision making, and memory and judgment. Now, what happens, because, and many times we have seen the children on autism spectrum, they have poor emotional regulation. They are not able to regulate their feelings. They are not able to express their feelings. Sometimes they might be crying continuously. You might give him that, you might feel he's having a tantrum. You might give him that chocolate, but in spite of that, he might continuously cry, because he goes into a state of sensory over meltdown. That means his limbic system gets overstimulated. Normally what happens, you have a connection between the limbic and the cortical system. So normally in a typical child, in a neurotypical child, what happens? He's continuously crying. He's continuously crying. I want chocolate. I want chocolate. I want chocolate. So that means he's an emotional dysregulation, is emotional overregulation is happening. Not dysregulation, emotional overregulation is happening in the child. He keeps on crying. You give him a chocolate. The cortical system, which is present there, he says, okay, limbic system, you keep quiet. You got the chocolate, now be relaxed. So there is a negative feedback goes into the limbic system from the cortical system of the brain, that you got the chocolate, relax, control your emotions. And he plays fine. That typically happens in a neurotypical child. But if I talk about a neurodivergent child or an autism child, he keeps on crying, he keeps on crying. You give him a chocolate, in spite of that, he keeps on crying, because his cortical system, the subcortical region of the brain, is poorly developed. His limbic system is overdeveloped, or is dominating the cortical system. He is not able to give a negative, it is not able to give a negative feedback to the limbic system and tell him, okay, you keep quiet, control your emotions. You have gotten a chocolate, then why you are still crying? Because the limbic system has over-empowered the cortical system and he keeps on crying. That is what we say the child has gone into a state of sensory meltdown. So that means to say the connections between the cortical and the limbic system are poor. Means there is no positive and negative coordination between the two systems, which should actually happen depending upon the scenarios, depending upon the state, depending upon the situation, depending upon the emotions. So how to integrate these primitive reflexes? To integrate these primitive reflexes, there is a theory, there is a movements, there are certain exercises which are known as rhythmic movements. Rhythmic movements. Now, rhythmic movements are innate movements an infant makes that are responsible for foundation of the posture, maturization of the vestibular system, overall neural development, sensory processing, and emotions and behavior. So when we give primitive reflex integration exercises to the children of primitive reflexes, there are certain movements which have to be given. And when we give those movements, we are trying to integrate those primitive reflexes, that is retain primitive reflexes, we're trying to remove them. Invariably, we are making these back portions of the neuronal connections of the brain poor and improving the brain functions in front of the brain better. That is neural connections. So replicating the earliest movement patterns, building the strong nervous system. See, one thing is very important. If there are primitive reflexes are there, that means your body is disorganized. He is showing jerky movements, he is showing here and there, is not organized. That means if your body is not organized, your joints are not organized, then definitely your sensory system is not organized. So what are these rhythmic movements? Rhythmic movements are basically were originally originated by the term, they were basically in the mid-90s. There was a doctor called Harold Blomberg. He was a psychiatrist. He basically started using these movements for his patients who were having polio. So he found that when he started using these movements on these polio patients, they become much, much better. And as a result, from there in 2003, Moret MC, he's a kinesiologist. So he was a person, but basically she was the person who introduced this Rhythmic Movement Therapy International organization and started giving training on these rhythmic movements. So I have done my training in these rhythmic movements. I'm certified in level 2. So they are different levels are there. I'm done my till level 3. So level 2. So this is how this concept of rhythmic movements therapy came. So movement is essential for the development of the nervous system. If there are no movements, your body will be dull. There won't be any movements. That is why movement is very, very important. That is what exactly we do in this rhythmic movement therapy. So there are some typical qualities of these rhythmic movements. It should be smooth. It should be smooth. It should be symmetrical. It should be effortless. It should be coordinated, symmetrical. I've just given you the characteristics of these rhythmic movements. How to do it, how to integrate each reflex. There are separate movements for each reflex to integrate. That is beyond the discussion of today's topic because it takes another 6 hours to discuss on that. So in a very simple way, if the body is disorganized, our emotions are also likely to be disorganized and our thoughts will also likely to be disorganized. That is why we need to keep our body organized so that our brain is organized, our emotions are organized. So to conclude, primitive reflexes still are active. You have uncoordinated movements, you have poor processing, you have poor maturization of the brain system. Now, in last, if I go about the sleep disturbances in autism, that is our last topic for today, I hope. So sleep disturbances is another important topic in children autism spectrum disorder. So as per the latest census from disease of central control, CDC, as per 2022, the latest prevalence of ASD is 1 in 44 with 4:1 ratio in female to male. And 40 to 80% of ASD kids suffer from insomnia. This is the stats which has been given from CDC. So that clearly indicates that sleep disturbances are very common in ASD. So what are the different spectrum of sleep disturbances? 54% might have disturbances, the resistant sleep problems. 56% might have insomnia, that is they don't go into sleep. 25% might have disturbed sleeping, that is they might go for a sleep but they continuously breathe. They might have bronchiolitis, allergic issues, adenoids. 31% may have a lot of daytime sleep and night they don't go any sleep. So hence we can say that there is a lot of evidence to show that sleep disturbances are very common in ASD. So how to approach these sleep disturbances? If I go into the causes of sleep disturbances in autism, they are multifactorial. It can be genetic, it can be neurological, it can be environmental, it can be food intolerances to casein and gluten. So let's discuss one by one and let's discuss on the management part. Now, for genetic factors, we cannot do much about that. As I have told you, there is one genetic mutation which has been found, that is neuroglin 3 has been found. And another important thing, they have found there is a disbalance between the GABA and the glutamate. As GABA is inhibitory and glutamate is excited neurotransmitter, GABA always remains in a state of excitation and glutamate remains in a state of low. So as a result, there is always an anxiety levels in the body. So sleep disturbances do happen in children on autism. Another genetic mechanism, they say there is a neuroglion 3 disturbance which is there. So as I've told you, genetics is generally beyond our scope. We cannot do much about that. But beyond that, a lot of things which we can work on to improve the sleep disturbances, and sleep disturbances do improve in children on spectrum. So neurotransmitters, as I've told, glutamate like GABA, melatonin, and glutamate. Now melatonin, again, I've told you, melatonin is very, very responsible for maintaining the normal sleep rhythm. In children on sleep disturbances with autism spectrum disorders, the melatonin levels go down, and whereas the other levels goes up, along with GABA and serotonin, and glutamate goes down. So there is an melatonin abnormal regulation in the body in children on autism spectrum. So do we need to give melatonin directly in a single step on the first go to treat sleep disturbances? Answer is no. Melatonin is basically a hormone, though it doesn't cause any problems, it doesn't cause any side effects, it's considered to be safe. But the first line of treatment for managing sleep disturbances in autism is not melatonin. That has to be very, very clear. It is not the first line of management. So neurotransmitters, so there is a disbalance between melatonin, GABA, serotonin, most importantly, along with glutamate. So this sleep circadian rhythm is disturbed. As a result, melatonin sleep issues happen in children on autism. So environmental factors, this is important where we can work. Inadequate sleep hygiene, poor sleep habits, hypersensitivity to environmental stimuli, problem with self-regulation. The most important thing which we need to figure it out, sleep disturbances, sensory issues. The child might be having a lot of tactile issues towards the texture of the clothes. He might be having tactile issues towards the type of clothing he's wearing in the night. He might be having proprioceptive issues. He might be having so a mother might give him a joint compression, he might feel better. He might be having visual issues. He might not like the brightness in the room, or he might not like the darkness in the room. He might be having auditory issues. There might be some family members who might be watching TV in the next room. He might be disturbing him. So without considering and thoughting those processes, we directly put the child on a melatonin. That is not the right approach. We need to look into these environmental factors, because these are some of the factors where we can actually work on the child in order to improve his sleep, along with other things where we'll be discussing. And many a times, as I've told you, 99% of the kids on autism have sensory processing issues. So definitely, if you are able to work on these environmental factors, 50% of the sleep issues will be resolved. That I can guarantee and assure you. Second most important thing where we can work is food intolerance. Many a times we might be giving him gluten or some food products which is intolerating him. That he might be taking a lot of citrus fruits. He might be taking a lot of fruits which might be high in yeast. That might be disturbing him. He might be having a lot of humming, uncontrolled laughter, excessive gut issues in the form of intolerance to gluten and casein. As a result, we need to look into those things. Does that child happening? Does there are a lot of frequent issues of constipation and diarrhea? So children with autism have high rates of sleep disturbances. 44 to 80% of sleep disturbance in autism spectrum disorder in various studies, compared to 20 to 25% children with sleep disturbance who are not ASD. So this is the normal sleep architecture or sleep stages in sleep. I don't want to go into the detail of this, because the only thing which I want to show is that the most important problem which we feel in children with autism spectrum disorder is difficulty in going for a sleep. The time lag in going for initiation of the sleep is the most important. There we might see the child is on the bed, but he will not sleep. He will be roaming here and there, curling, and it might take 2 hours, 3 hours for him to go for a sound sleep. That is the most important type of sleep disturbance which has happened. That is called as disturbance from going to the stage 2, stage 3. That is initiation of going to the stage 3 sleep is that is what is known as non-REM sleep. That is non-rapid eye movement. That is a technical term I'm using, but just remember the difficulty in initiation for the child to go into the sleep is difficult. So what we can do for the sleep disturbances, there are certain polysomnographies. These are just for only research purposes. These are generally not recommended and generally not done. These investigations are not generally done in children on autism spectrum. So what are the consequences of sleep disorders? If the child is not taking a good sleep, he will have obesity, he will have other issues, medical issues, weight gain, constipation issues, academic problems, poor academic skills, hyper activity, impulsivity, anxiety issues, poor performance in school, poor performance in therapies, aggression, all those things will start developing. And ultimately what happens, we might put up the child into an schizodon or risperidone, thinking his aggression, his behavior is increasing. But unfortunately, those things are happening because of sleep disturbances. Though risperidone will help in improving the sleep disturbances, but we need to weigh the benefits versus risk. We know that the risk of risperidone and schizodon are much, much higher compared to the benefits. But once you are putting a child on risperidone, we need to think at least 10 to 20 times before putting a child on risperidone. Because many a time the aggression and behavior are because of his lack of skills, either due to lack of communication, lack of expression, lack of making him understand his medical problems, lack of making him understand his found food. So those things need to be worked upon rather than directly working on the aggression. With many a times what happens, the child is not able to express, I'm feeling hungry. He starts throwing things, he starts snatching, he starts waving. So parents think he's having aggression. They might go to a doctor, the child might put him on a schizodon. But that is not the right approach. You need to figure it out why that aggression is happening. If we are able to work on those fundamental things, probably we need not put up a child on those antipsychotic medications. So the impact of sleep disturbances, this was the impact of sleep disturbances on children. This is the impact of sleep disturbances on the parents. They have a poor quality of life. The social interaction is affected, further aggression, activity, and hyperactivity, irritation happens in the problems in families. So the conducive environment of the family gets cold disturbed. So what we can do for how to manage these sleep disturbances, the first and foremost thing is check for the precipitating and predisposing factors. That means, is the child taking any drugs? Is the child having any sleep issues? He's having any medical issues, means any gut problems, any constipation issues, any allergic issues, any nose blockage issues, any adenoids issues, any seizure issues. Along with that, these are some of the predisposing and precipitating factors. Along with that, there are some perpetuating factors, means which can worsen, which can increase. What about his daytime nap? He might be taking many a times parents say, sir, raat mein sota nahi hai. Just ask, what about how much time does he take in the daytime? Sir, wo din mein 3 घंटे sota hai. तो रात में कैसे बच्चे सोएगा? How can you expect him to go for a sleep? So the most important sleep, see, the thing is the child should go for 10 to 12 hours of sleep in 24 hours. This is the norm. If he's sleeping 7 hours, if he's sleeping 5 hours in the morning in the daytime, and he's sleeping 5 hours in the night, that is okay. He's taking 10 hours sleep. He's not a sleep disturbed child. The problem is he's taking a daytime nap. So you have to cut down on the daytime nap. That is very, very important. So maintain a sleep log or a sleep diary to check what about his sleep pattern. Evaluation of the bedtime routines is very, very important. So before going into the details, so before managing the sleep disturbances in a child, it is very, very important to take a deep, comprehensive, detailed sleep history when managing a child on the sleep disturbances. Data collection should include bedtime, waking time, napping time, waking hours, and how much time he has been associated with behaviors. Daytime functioning, how about his functioning? What time, how many times he has taken the nap? Along with that, there are some certain questionnaires are there, like which we use generally, children's sleep habits questionnaire. So this questionnaire basically gives you an idea that at what time he's going for the bedtime, at how much time after going to the bed he falls asleep, how much time he's taking the day-night nap, when he gets up in the between in the night, what about his behavior? When he's getting up in the morning, how about his behavior? When you cut down on his sleep pattern in the daytime, how about his behavior? So all those things need to be recorded. And then only we'll be able to figure it out that what are the issues, what are the sensory issues. Along with that, you need to note down what about his sensory issue. Does he feel comfortable in light clothes? Does he feel comfortable when you change the texture of the clothes, of the bed sheet? Does he feel comfortable when you reduce the temperature of the AC? Does he feel comfortable when you are near to him? Does he feel comfortable when the bright lights of the next room is switched off or the TV is on? All those things need to be taken into consideration rather than putting the child directly on the melatonin. So rule out other medical problems, gut problems, as I've told you. So rule out environmental causes, auditory, visual, all these things I've discussed. So how you can establish a good sleep hygiene? The good sleep hygiene you can establish, maintain a good sleeping bedtime. Relax before bedtime. There should be a gap between sleeping and bedtime, sleeping and food of at least 2 hours. Should not be any, you should not watch any TV while having food. All the family members should take the food at a right time. That means on the dining table or any time. There should not be any mobile usage, even for the family members. Many a times parents might be watching TV and having food. That should be avoided. 1 hour of physical activity is very, very important in during the daytime. Avoid giving them any, chocolates or any food products which contain high energy sweets during the night time. So all those things need to be taken into consideration, and meals should be healthy, millet based, or depending upon whether the child is gluten and casein intolerance or not. So this is about the sleep training pattern, which I have told you. Pharmacological approach, I have told you, like medications are there, but along with that, medication should be considered if behavioral interventions are ineffective or difficult to be implemented, especially in individuals with low functioning autism, and should be used in combination with non-pharmacological strategies, which result in more sustained improvement. This is what I told, and this is what the stats and this is what the guidelines say, that medication should not be considered immediately. They should only be considered when you have failed out on behavioral issues, when you have failed out on medication sensory issues, when you have failed out on diet issues, when you have failed out environmental issues, and then only you should think of putting a child on medication, because in that case we are thinking that the melatonin levels in the child is. Now, what is the percentage of melatonin low in children with autism? It's not that more than 70%. It's the figure is low, but it has been found that some percentage of children on spectrum have low melatonin. Now, if the melatonin levels are low, we cannot do anything about that. We have to supplement with the melatonin. But that percentage of melatonin, low levels of percentage of autism is low. That is why melatonin should be recommended hardly to 15 to 20% of the kids on spectrum, because only in that percentage of figure, the levels of melatonin are low. There is no test where we can detect that, yes, the levels of melatonin are low. There is no blood test. So these are the summary of various medications: melatonin, shizodone, and all these medications, clonidone. And these are various list of medications which have been tried and given for sleep disturbances. But in my practice, I have only given melatonin, and that too, as I've told, only when the other factors we are not able to work on. Many a times when I worked on the gut, many a times when we work on the environmental and the gut specifically, because I'm not a sensory integration therapist, many a times when I work on the gut problems, when I work on those intolerance issues, many a times sleep issues get better. Even if we want to give melatonin, we have to give only for a certain period. Then on a long-term basis, we are able to remove the child of melatonin. So, but giving melatonin is safe. It can be given over a longer period of time without any much side effects. Other sleep medications like shizodone vagara, we are generally not using it because the benefits are less compared to the harmful side effects. So this is all about today's masterclass, and I hope we finished well in time. So we have some 15 to 20 minutes for the questions. I hope I have not bombarded you with a lot of information, but I have just picked up small important topics which are very, I would say controversial, and where not much discussion is being done on autism. And so I try to pick up those topics, and I try to pick up those important facts from those topics and latest evidences and research which is going about on autism. So it was just basically to make you understand aware what is all going about autism in today's world. Thank you every parents, thank you participants for joining today. So now we are open for the questions. If anybody's wanted to ask some questions or any doubts, we can clear that.
Hi, doctor. My name is Vishnu. Can I go for a question?
Yeah, please.
So the regarding the decision of what therapies are good, the parents should take a call. So how do we arrive at what are the therapies available and what is best?
Sorry, your voice is. Can you speak a little louder?
Yeah. So on the concept of the parents should take decisions on the therapies, right?
Yes.
Yeah. So I mean, how do we know which therapy is best, and how do we consolidate a list of all the therapies available?
That's that's what I'm telling, that on this is what comes under the step 2. First of all, in the step 2, where you have to do is we should get a formal assessment of the child done with a sensory integration therapist, with a developmental pediatrician, or with a clinical psychologist. Clinical psychologist role only comes when the child is above the age of 6 years to check for his IQ. And as I have told you, only 15 to 20% of the children on spectrum have low IQ. So that category of children needs to be that only up to 6 years. So once you go for a sensory profiling, once you go for his developmental assessment, you get an idea of the child, that where my child is coming on the sensory issues, what are the severity of my sensory issues, and accordingly you can go for the sensory integration depending upon the requirement. Secondly, regarding his other factors like behavioral issues, like suppose you go for an assessment with a developmental pediatrician. He puts up a scoring of cars where he will check his verbal issues, he check his emotional issues, he check XYZ reasons, and comes out with a score like he's in under category of mild to moderate. But forgetting about that category of mild to moderate, you will get 15 to 16 parameters on those scale where you will get an idea that yes, my child is having those issues, and these are the things where we need to work upon, and accordingly you need to prioritize that yes, right now I need to give my child, suppose your child is 2 years, he is under the category of mild to moderate issues with high sensory issues. So here your priority is not right now to include special education, to include speech therapy. Your priority is to introduce sensory integration so that his sensory system gets settles down, and as a result then you can focus on other therapies. See, if your sensory system is not settled down, even if you go for an AB, if you go for a speech therapy, he might not be comfortable, he may not be able to repeat, he might not be able to understand because he's so much fidgeting with himself because it's not comfortable, his sensory system is not calm. So in that case you need to prioritize, and in that case your professional also in decision with you should prioritize that right now first 3 months you should go for this and then you should go for this. So this is how the prioritization of therapy should be done rather than putting 9 therapies at a single group. Okay.
Okay, sir.
Okay, thank you.
Hi, Doctor. Doctor, good evening, Doctor.
Yeah, good evening.
This is Bhagat. Can you give some examples of primitive reflexes? What kind of exercise, at least few of them, will be helpful?
See, the most important things, if you go for the primitive reflexes, first and foremost, the reflexes only for the Moros I can give you, because Moros is one of the reflex which is present in 90% of the cases, it is retained. So there are certain exercises where you can do that. It's better if I can share you, because if I give you the names, that because that will not be beneficial, we can share you the postures of the exercise. Okay.
Yeah.
Because if I give, yeah, so that we will share you some 3 to 4 exercises so that you can do with your child, that we can share.
Yep, okay. Sure. Thank you.
Okay, thank you.
One more question, Doctor.
Yeah.
Like when time of the maternity time, like normally, like you said, like we need to have with the autism might occur like when the depression or you said like some points like depression or like the some
yes,
I missed that point.
it might be family stress, environmental stress, etc. Yes.
Yep. Is there any like you mentioned like one more thing like the TV time we can have less time like or maternity time or the baby time like when 1 to like within 1 year it should be 0 TV time, the screen time.
Yes.
So is that correct or like what exactly? Can you give some because I missed that initial part.
See, the thing is, when the child, generally when the child is less than 1 year, you should not give any screen time. It should be 0 screen time. Okay. And when a child is up to the age of 2 years, you can give him a screen time of up to 1 hour per day. After the age of 2 years, you can give a time of screen hours up to 1.5 hours per day maximum. Beyond 5 years, there is no such guideline. Beyond 5 years, it is up to the child and up to the parents that as per the needs they can watch. But beyond 2 years, whenever you are giving a screen time, there should be 1 hour of physical activity, which is must for a child.
Okay, sure.
Okay.
Okay, thank you.
Okay. Okay. Thank you. So I think there are no more questions, so we can close up the session. Yeah. Okay. Thank you. Thank you, participants, for joining. I hope we had a good interaction with each other. So the recordings will be available to you for 1 month. It will be shared on your WhatsApp number. So thank you once again. Have a great day. Good evening to all of you. Thank you. Thank you for participating. Thank you very much.
Thank you.
Thank you.